Hey guys, I hope I'm live and audible to all of you. Give me a thumbs up in the chat box if I'm audible to you so that we can begin with the session. Answer Ahmed Khan, welcome. So today we are starting the Farre Series for the final crop exam. Now what is it primarily aiming to achieve? Well, it is for those students who are trying to prepare for their final prof exam and they are kind of underprepared. So we are going to hold your hand sufficient enough for you to pass your prof exams. Okay. Of course, this is not going to be a very elaborate discussion on the topics. For that, of course, I am doing a Reed Harrison series where I discuss everything in sufficient detail. So if you're in third year or beginning of your final prof, or you want to study the medicine in detail, I would suggest follow the Reed Harrison series. But for quickly getting through your final prof exam, here we have the Farre series. So today we will be starting with respiratory medicine. We will try to cover important topics from the respiratory medicine. Of course, in covering the topics, we have gone through the questions from various university exams and we have tried to come out with those questions, and I will teach you how to write answers. As an examiner, I myself is an assessor for the papers. As an examiner, what do I expect in students' answer? Please remember that this is not a NEET PG class and we are not going to focus more on MCQs. We are going to focus more on what to be written in your prof exams. Okay. So we'll start with the topics that we're going to cover. We will try to cover asthma, what kind of questions can be asked from asthma, COPD, pulmonary hypertension, and respiratory failure. So let us begin with the asthma. Now, what kind of questions can be asked in asthma? Asthma as a whole can be a 10-mark question. So they can ask you to write everything related to asthma from clinical features, diagnosis, as well as management and complications in 10 marks. Or else they can ask you to define asthma, and they will also ask you to differentiate between different types of asthma. Define and discuss the types of asthma can be a 5-mark question. Or they can also ask you about the general management of asthma and management of acute severe asthma as a 5-mark question. So we'll try to cover all these three: asthma as a whole, differentiating between different types of asthma, and general management of asthma and management of acute severe asthma. We will begin. Whenever they ask a question about asthma, though the question may not ask you to define, it is always considered wise to begin writing the answer by definition. This will take 1 minute out of you, but gives an idea to the examiner that you know the subject well. So always try to define if it is a 10-mark or a 5-mark question. Not for a 3-mark question or a 2-mark question, but for 10, 20 or 5-mark question, depending on your university, begin with definition. Now, how asthma is defined? Asthma is defined as a chronic inflammation of the airways. Most important thing that we have to remember, or you have to ensure that you highlight, is that asthma is a disease primarily affecting small airways. So if you highlight this, the examiner is going to be pleased. Second, of course, COPD also affects small, medium, and large airways, and examiner wants to know how is it different from COPD, how asthma is different from COPD. So in the definition, I want you to mention that COPD is also an obstructive airway disease, but asthma is characterized by reversible obstruction and COPD is characterized by persistent obstruction. If you cannot write all this in one sentence, what you can write about asthma? Asthma is a obstructive airway disorder, characterized by reversible obstruction, So as long as the reversible obstruction word is seen, examiner will be pleased. So that is the first point that I want you to remember to write when it is a question on asthma. Now, once you have written down the definition, now next thing is you should talk about the clinical features. Now, for the respiratory system, writing about clinical features is easy. Even if you don't know anything, of course, you can include two symptoms. What are those? The first symptom that you will of course mention is patient will have shortness of breath or dyspnea. Whether it is interstitial lung disease, pneumonia, pneumothorax, pleural effusion, or tuberculosis, or the idiopathic pulmonary fibrosis, sarcoidosis, or asthma or COPD, shortness of breath will be a common complaint. Shortness of breath. And second thing I want you to mention, apart from that, these patients will also have often cough. And third, this is often associated with wheeze. So mention these three symptoms in the clinical features. and try to mention that these symptoms are not persistent, they are episodic, because whenever there is an asthma attack, the symptoms will appear. When the asthma attack goes into remission, the symptoms will disappear. So make it a point that you mention that the symptoms are episodic. And I also want you to mention that the attacks are typically more common. Attacks are more common in the early mornings, more common in early mornings. So this kind of describes the clinical features, and examiner know that you know the basic points. Okay. Now I want you to write the trigger points for asthma, because asthma happens in episodes. So that means something triggers it, right? It's not a persistent symptom. Patient is not continuously coughing. Patient is not continuously wheezing. Patient is not continuously short of breath. So something triggers it. So make it a point to mention at least few things which are known to trigger asthma. Okay. So now I want you to write few things more specifically. Don't miss writing about the allergens, because we all know and examiners also know, right? Second, why is it more common in early morning hours? Because of exposure to cold air. That is the second thing I want you to mention. Then exposure to aspirin and beta blockers. Drugs are known to trigger asthma. Apart from that, airway irritants like sulfur dioxide and paint fumes. These are airway irritants. They can also precipitate asthma attacks in a patient who is having asthma. Okay. These are the most important things I want you to write. If you omit rest of the things, it's fine. If you have little time, talk a little bit about exercise, because there is something called as exercise induced asthma. Exercise induced asthma, or EIA. If you have time, write about it. Otherwise, mention mainly the allergens, infections, drugs like aspirin, beta blockers, and airway irritants. This is about triggers. So far what we have discussed about what is asthma, how to define it in the exam, what clinical features I should write, and then what triggers I should be mentioning. Once that is done, we will go to the investigations. Now you can definitely write a long list of investigation, but please remember, examiners are not interested in knowing all those fancy, rarely performed investigations. So what I want you to write is, first, the investigation of choice for diagnosis of asthma is pulmonary function test. If you have time, you can write about chest X-ray. Does chest X-ray has a role in diagnosis of asthma? No, it has no role in asthma diagnosis. Okay, that's clear. So it's mainly the pulmonary function test. So now how pulmonary function test will help me to make the diagnosis of asthma? In the pulmonary function test, the parameter that we are interested is forced expiratory volume in 1 second divided by forced vital capacity. This ratio. Now what is the normal ratio? The normal ratio, FEV1 by FVC normal ratio is more than 0.7. And if it is less than 0.7, what does that indicate? It indicates that patient has an obstructive airway disease. He has an obstructive airway disease. Now, is obstructive airway disease equal to asthma? Of course not, right? So once we have confirmed that patient has an obstructive airway disease, I have to prove, we have already defined asthma as reversible bronchoconstriction or reversible obstruction. So I have to prove that this obstruction is reversible. Now, how do I prove that the obstruction is reversible? There is something called as bronchodilator reversibility test. So after this, so this is the step 1, you can say. Step 1 for the diagnosis of asthma is to do PFT, FEV1 by FVC ratio. If it is less than 0.7, it is obstructive airway disease. And after that, we do something called as bronchodilator reversibility test. Bronchodilator reversibility test. So what does that mean? We give a bronchodilator. What could be a bronchodilator? We administer inhaled short-acting beta agonist. Short-acting beta agonist, nebulization or a metered dose inhaler. And we will see what happens to patients' FEV1. If patients' FEV1 increases by more than or equal to 12%, that means the obstruction is reversible. And if FEV1 increases by less than 12%, FEV1 does not increase at all, increases by less than 12%, means 0 to 12, no increase, or up to 12%, like 11 point odd. 12 or more, it is reversible obstruction. So this indicates that you have reversible obstruction. And if it is less than 12% indication, it means it is persistent obstruction. So when I have persistent obstruction, what are my differential diagnosis? If it is persistent obstruction, I would consider diagnosis of COPD or bronchiectasis. Bronchiectasis. On the other hand, if it is reversible, it is clearly a case of asthma. In that case, the diagnosis becomes asthma. I want you to write this algorithm because instead of describing this whole process in detail, if you write the algorithm, the examiner is very much pleased that you know the protocol or the approach, and he will give you the full marks for the diagnosis or investigation. So step 1, you have to write that I will begin with FEV1 by FVC. Investigation of choice is PFT. If FEV1 by FVC is less than 0.7, then it is obstructive lung disease. Now, to differentiate whether there is reversible obstruction or persistent obstruction, I will administer a short-acting beta agonist. After that, if FEV1 increases by more than or equal to 12%, it is reversible obstruction. I will make a diagnosis of asthma. For an undergraduate student, there are no other differential diagnoses for reversible obstruction. Clear? And if less than 12% increase in FEV1, then I would think of persistent obstruction. In that case, it could be COPD or bronchiectasis. Those are my differential diagnoses. Okay. Now, what other investigations can be done for the diagnosis of asthma? Just X-ray we have discussed. What else we can do? Other investigations, you don't have to elaborate on them. Even for a 5-mark or a 10-mark question, you have to just mention what other investigations we can do. Okay. So the first one is fractional exhalation of nitric oxide or FeNO. Second one is called as methacholine challenge test. Methacholine challenge test. Now, what do we do in fractional exhalation of nitric oxide? We ask the patient to exhale the air, and from the exhaled air, we will measure the nitric oxide exhale. Whenever airway is inflamed by eosinophils, large amount of nitric oxide will be exhaled, which we can measure, and indirectly we can say that airway is under inflammatory attack by the nitric oxide. Methacholine challenge test primarily try to stimulate or precipitate an asthma attack in someone who is prone for asthma. Okay, these are not routinely performed these days, especially the methacholine challenge test is not routinely performed. So as long as you're able to write about the PFT and the algorithm, you're good to go for the diagnosis. Once the diagnosis is done, I want you to write about the types of asthma. And when it comes to types of asthma, there are 2 ways of classifying asthma. The first one is the traditional classification as intrinsic and extrinsic asthma. Most of the examiners are familiar with this classification, and definitely they want you to write about it. But I will also tell you one more method of classifying asthma, which I want you to remember and write in the exam. This intrinsic versus extrinsic. Now, what is the meaning of intrinsic? Something inside. What is the meaning of extrinsic? Something outside. So based on the trigger, whatever is triggering the asthma, whether it is coming from within or whether it is coming from external environment, we classify asthma into intrinsic and extrinsic. Okay. Extrinsic asthma is also called as atopic asthma because these patients have allergy to something from outside the human body, like pollens, dust particles, right? Dust mites, some fumes, they are allergic. Okay, so that is why there is a strong association with allergy in extrinsic asthma patient. There is no relationship with allergy in intrinsic asthma patients. Why there is no relationship with the allergens in the intrinsic? Because the trigger is usually inside. What is the trigger in case of intrinsic asthma? It is usually infections, respiratory infections. The triggers for the extrinsic asthma is usually allergens. So if you look at the serum IgE level, right? IgE has a role in allergy. So of course that will be high in the extrinsic asthma patients and it will be normal in intrinsic asthma patients. Okay. Then allergic tendencies may have a family history. Intrinsic, no allergy, so probably no family history. Okay. When it comes to gender predisposition, males are more affected in extrinsic, but males and females are equally affected in intrinsic. Age of onset, the extrinsic is having childhood onset, and the intrinsic is having adulthood onset. Okay, now comes a point. The most important point that you have to write about intrinsic versus extrinsic asthma is who carries a better prognosis. Is it the intrinsic type or extrinsic type? I am reminding you again, the intrinsic type, the onset is adulthood, and extrinsic type, the onset is childhood. So who carries a better prognosis? Is it the intrinsic people or the extrinsic people? Or in other words, childhood onset or adulthood onset? What do you think? Is it better to have asthma diagnosed right in your childhood or get asthma diagnosed once you become adult? The answer is very, very important here. Which asthma likely to carry better prognosis? Remember, if you take a child to a pediatrician and say, sir, my child has got asthma, most often you will hear pediatricians saying that, ma'am, don't worry, the child will outgrow the asthma. What does that mean? Majority of the children who are diagnosed with asthma in childhood, they do not continue to be asthmatics in the adulthood. As they progress through teenage, their asthma wanes away. So they are not going to carry this asthma into adulthood. But on the other hand, we generally say in adult medicine that if you're diagnosed with asthma for the first time in adult life, either asthma takes you to the grave or you take the asthma to grave. So the adulthood onset asthma or the extrinsic asthma is not going to go into remission. It will stay with you. It may be well controlled or it may not be controlled, but it will stay with you. So that is why the prognosis of the extrinsic childhood onset asthma is good. The prognosis of intrinsic or adulthood asthma is poor. Now, one more thing I want you to write here, apart from this table, is there is something called as Santosh triad, and you should write which of these type of asthma is associated with Santosh triad. Santosh triad. And I definitely want you to put a nice triangle so that it is eye-catchy to the examiner. So remember, Santosh triad is associated with the intrinsic asthma. Intrinsic asthma. Now, what comes under Santosh triad? We have asthma, presence of nasal polyps, and aspirin hypersensitivity. Aspirin hypersensitivity. So make it a point to write a nice triangle and write the three features of Santosh triad and mention that it is associated with intrinsic asthma, nothing to do with the extrinsic or childhood onset asthma. This is the traditional classification of asthma, right? So there is also a newer phenotypical classification of asthma. I want you to definitely write about it. Newer phenotypical classification of asthma. Now, what is it based on? This is based on the pathophysiological process. So the asthma is classified into two types. The type 2 asthma and non-type 2 asthma. Non-type 2 asthma. So I want you to write few features about these two. Now you should tell me, why are we calling something as type 2 and non-type 2? Why are we not calling it as type 1 and type 2? Like diabetes, we have type 1, type 2. Right? Respiratory failure, we have type 1, type 2. Pulmonary hypertension, we have type 1, 2, 3, 4, 5. So now numerical system always follows the order, right? Why are we calling here as type 2 and non-type 2? Because it is based on the Th cell involved in the pathogenesis of asthma. So Th, the helper T cells which are involved in the pathogenesis of asthma. Th cells involved. In the type 2 asthma, it is the helper cell type 2 or Th2 cells which are involved. That's why it is called as type 2 asthma. On the other hand, in the non-type 2 asthma, it is the Th1, Th17 and other helper cells which are involved in the pathogenesis. Okay. Now these are helper T cells which help the body to recognize the antigens. But do helper T cells cause the damage to tissues? Here in asthma, there is inflammation of airway. So do you think helper cells are directly causing the inflammation? No, they are just the helper cells. They will tell that there is an antibody, you need to react to it. So they are just doing helping task. Now, who is doing the inflammation to the tissues? Neutrophils or eosinophils. Now, how helper T cells will tell the eosinophils or neutrophils to go and attack the tissue? By sending some cytokines, right? So we'll call them as cytokines or inflammatory cytokines that are involved in the pathogenesis. What cytokines are involved in the pathogenesis of type 2 asthma? In type 2 asthma, we have interleukin 4, interleukin 5 and IgE, which are involved in the pathogenesis. In non-type 2 asthma, we have interleukin 6, interleukin 1, right? These are the main interleukins or cytokines which are involved in the pathogenesis. I will definitely tell you why this is important, and I hope that you will remember these points and you will be able to recreate in your exam. Now, these cytokines will go and tell inflammatory cells to cause the inflammation. So basically, helper T cells recognize the antigens and tell that, okay, there has to be an inflammatory response. So for eliciting the inflammatory response, there will be release of these inflammatory cytokines. These inflammatory cytokines will go and bring the final cells which will cause the inflammation. We will call those cells as effector cells. Effector cells which will cause the inflammation. So the effector cells involved in the type 2 asthma are primarily eosinophils. And effector cells which are causing the inflammation in non-type 2 asthma is neutrophils. Now why this is zygote, I will take that question. So why this is important? Just I will give you an example. I have a drug called as dupilumab. Anybody knows its mechanism of action? Dupilumab. Dupilumab is a monoclonal antibody against interleukin 4 receptor. It blocks the interleukin 4 receptor. So if I want to use this drug, can I give this to a patient with non-type 2 asthma? It blocks interleukin 4 receptor. Is interleukin 4 involved in the pathogenesis of this patient's non-type 2 asthma? No, right? So if I give this drug to non-type 2 asthma patient, will it help the patient? Of course no, because there is no role of interleukin 4 in the pathogenesis. What it can do instead? Adds cost burden, right? Unnecessarily patient is paying so much money, and of course whatever side effects we can get, we will definitely get. On the other hand, can I use this drug for a type 2 asthma patient? Yes, because interleukin 4 is involved in the pathogenesis of type 2 asthma, right? So that's why to decide about more higher treatment protocols, we need to know whether it is type 2 or non-type 2. So what we have learned so far, if there is a question on asthma which is for 10 or 20 marks, begin with the definition. In the definition, make it a point that you mention it is a reversible airway obstruction disorder primarily affecting small airways. These are the 2 points: small airways, reversible obstruction. After that, diagnosis, mention investigation of choice is PFT. Write the algorithm for the PFT based diagnosis. I want you to write how you diagnose. Just give me a second. How you diagnose, how you make a diagnosis of obstructive airway disease, and after that how you differentiate between reversible and irreversible obstruction using the bronchodilator reversibility test. Definitely you should write the values correctly. Okay. After that, classification of asthma, intrinsic versus extrinsic. Mainly the points you have to write is the age of onset, severity, triggers, and presence or absence of Samtus triad. And second, you have to write about the phenotypic classification into type 2 and non-type 2. Main thing you have to remember here is don't miss to mention eosinophils and neutrophils as the effector cells involved. Okay. Now, another thing that they would ask you is markers. This can be a 2-mark question. Markers of type 2 asthma. Markers of type 2 asthma. Now that we know type 2 and non-type 2 asthma, the examiner would expect that you should be able to diagnose or differentiate between type 2 and non-type 2 asthma. So how do I differentiate? Remember, first marker for type 2 asthma will be absolute eosinophil count. So if the absolute eosinophil count in a patient with asthma is high, That means what? Patient is having type 2 asthma. I can use this as a marker of type 2 asthma. Second, fractional exhalation of nitric oxide. I have already made a statement saying that when your airway is under the inflammatory attack by eosinophils, there is increased production of nitric oxide. So patient will exhale a lot of nitric oxide. Nitric oxide का role तो पता है. Nitric oxide causes vasodilatation. Inflammation matlab there is definitely some degree of vasodilatation. Whenever we have inflammation, why tissues become red? Because there is vasodilatation. And for causing that vasodilatation, there will be release of nitric oxide. So if patient is exhaling a lot of nitric oxide, that means it is coming from airway. Airway is under inflammation. Okay. And the third thing that we can use as a marker is serum IgE levels. Serum IgE levels. The Neurylama, soon the hard copies will be available. Already soft copies available on the app. You can definitely go through that. Okay. So this can be a 2-mark question. Markers of type 2 asthma, 2 or 3 marks question depending on your university. So please don't miss remembering this. Write 2 or 3 markers of type 2 asthma. So if I do these markers, if they are elevated, I will call that patient as having type 2 asthma. If these markers are normal, I will call that patient as having non-type 2 asthma. So now we know the definition, diagnosis, clinical features, as well as 2 different subtypes of asthma. Now we will talk about the management of asthma. Okay. Now, when it comes to management of asthma, how to write management of any disease in the written exam? So the approach that examiners would like is first enlist the treatment options available. Means what are the drugs available or what are the classes of drugs available for the management of a particular disease. After that, you have to give a protocol for making the management. Right? So first we will make a list of drugs available. What all I can use for treatment of asthma. Right? So I can classify the drugs used for asthma as bronchodilators and anti-inflammatory agents or disease modifying agents. We can classify them as bronchodilators and anti-inflammatory. Those who cause bronchodilation and those who cause anti-inflammation. So what class of drugs come under anti-inflammatory drugs? Of course, the corticosteroids. Corticosteroids, leukotriene modulators, and mast cell stabilizers. Mast cell stabilizers. What drugs come under the bronchodilators? What can I mention under bronchodilators? So remember now that bronchoconstriction or dilatation is caused by which tissue in the bronchi? The smooth muscles, right? Now smooth muscles are under the control. Are they under voluntary control? Can I decide to constrict or dilate my smooth muscles? Of course not. They are under the autonomic nervous system control, and we know that autonomic nervous system has sympathetic and parasympathetic. So one of them causes bronchoconstriction, one of them causes bronchodilatation, right? So what causes bronchoconstriction? Remember, the constriction is caused, the bronchoconstriction is caused by parasympathetic, and bronchodilation is caused by sympathetic. So now you tell me, if I want to cause the dilatation of a constricted bronchus, should I block the sympathetic nervous system or should I stimulate the sympathetic system? Already it is constricted, I want to dilate. What sympathetic does? Dilation. So should I stimulate the sympathetic or block it? Of course, I have to stimulate so that I can achieve bronchodilation. Similarly, if I want to instead take this route of parasympathetic to achieve the dilatation, what should I do? Should I block the parasympathetic or should I stimulate the parasympathetic? अगर parasympathetic को stimulate करूँगा तो I will cause bronchoconstriction. But if I block it, I can achieve the bronchodilation, right? So we try to block the parasympathetic or stimulate the sympathetic. So I have two classes of drugs available for me to cause bronchodilation. The first one is sympathomimetic. Sympathomimetics, which will cause bronchodilation, or parasympathetic blockers. Parasympathetic blockers. Now, the sympathomimetics, of course, I will be targeting the beta receptors because they are expressed there, right? So I will be trying to block beta. I will be using beta agonist. And as we know, beta agonists are of two types: the short acting beta agonist and long acting beta agonist. Just to please the examiner, make sure that you mention one or two examples of each drugs. Example for SABA, we can write is salbutamol. It is there in the name, salbutamol, SABA. And the example we can write for the long acting beta agonist is formoterol. Or you can also write about indacaterol. These are long acting beta agonists. Similarly, when it comes to parasympathetic blockade, should I block the nicotinic receptors or muscarinic receptors? Because we have two types of parasympathetic receptors, right? Muscarinic and nicotinic, just like how we have alpha and beta receptors for sympathetic. So what receptors are predominantly expressed in the airway smooth muscles? Again, I want you to remember the neuromuscular junction of skeletal muscles, which gets affected, the neuromuscular junction disorders like the GB syndrome. It is nicotinic receptors, but the smooth muscle neuromuscular junction carries muscarinic receptors. So we have to block muscarinic, right? So we use anti-muscarinic agents. We use anti-muscarinic agents. Now, when I have to think of using anti-muscarinic agents, they also are of short-acting anti-muscarinic agents or SAMA and long-acting anti-muscarinic agent or LAMA. We should write examples for both of them. The example for SAMA you can quote is ipratropium. Ipratropium. And the example for LAMA is tiotropium. Now, how do I remember this in the examination hall? It's pretty easy. Just look at the alphabetical order. What comes first? I, right? Shortly after you start saying A, B, C, I comes first. So I is short acting. You need to take longer time to reach T in the alphabetical order. So tio is long acting. Now these are the options that I have. Now the question, see, now I have mentioned the list of drugs available for the treatment of asthma. This is the right approach. Whenever you write for 5 marks or 10 marks, first mention what choices you have, and then you have to write how do you make a choice out of the available choices for initial treatment. Okay. Now, if I have a patient with asthma, what are his problems? What are his problems? There are two problems that asthma patients face. One, patients will have repeated attacks of asthma. So I need to prevent those attacks from happening, right? And second, whenever asthma attack comes, he will be going through wheeze, shortness of breath, discomfort. I have to relieve it. So medications that I use to relieve will be called as relievers. And the medication that I use for prevention of asthma will be called as maintenance medication. So there will be two categories of medications used for a patient with asthma. The first one is called as reliever. Reliever is used to relieve asthma attacks. This is not useful before the asthma attack has happened. It can only relieve an asthma attack. An example for a reliever is a short acting beta agonist. And for maintenance, the maintenance medications are those which are used for prevention of asthma attack. Prevention of asthma attack. So usually what medications we use for prevention of asthma attack? I can use long acting beta agonist because it will be acting long. It will prevent the constriction of the bronchi. Second, if I hit hard and prevent inflammation itself, then there is no bronchoconstriction. So we can use corticosteroids, mainly inhaled corticosteroids. So the drugs that can be used for relief are SABA. The drugs that can be used for prevention are LABA and inhaled corticosteroids. Most patients of asthma will require to use both the long-acting beta agonist and steroids for maintenance of prevention, as well as SABA for relief whenever there's an asthma attack. Now, how do I make a choice? Whom to give just the reliever medication, whom to give a combination of maintenance and reliever medication? There is a Gina guideline which gives us an idea about how to start the initial treatment. Okay. Now, if you can remember this, good. If you're not able to remember this, if you're able to write even this much, examiners will give you 60% of that marks. Like if he has kept 4 marks for the management of asthma, he will give you 2.5 or 3 for writing the drugs and the concept of a reliever and maintenance medication. But you will definitely get the brownies points if you're able to write the Gina guidelines, and make sure that you write that whatever you're writing is Gina guidelines 2024. 2024. Okay. So how do I start the treatment? If patient is having less frequent symptoms, less than twice a month, he is getting asthma attacks. In such patients, what we do is as needed low dose inhaled corticosteroid and formoterol. This is used as the initial treatment. Okay, now I forgot to address one important point. I'll take just 2 minutes out of you, but it's a very interesting and important point that I want you to know. Not for the exam, but if you know this, you will be able to do well in the exam. I had very difficult experience of treating asthma patients. When I started my practice soon after my PG, like 2012 or so, for first 6 months, I was fed up of treating asthma patients because most of my asthma patients will require a reliever to relieve an asthma attack, and they will also require a maintenance medication, a combination of LABA and ICS for the prevention. So 3 inhalers. What I used to do was like 1 inhaler, which is LABA, plus 1 inhaler, which is inhaled corticosteroids. I used to tell them that take it on a daily basis, right? Morning and evening for prevention of asthma attack. And in addition to that, whenever there is an asthma attack, take an inhaler which is SABA only when there is an attack. If no attack, you don't use SABA. You will only be regularly using LABA plus ICS combination morning and evening, and that will prevent the asthma attack. But 3 inhalers involved, right? So patients will come back after 3 months, and when I question them back, how are you doing? They're like, sir, terrible. The way I had come to you, situation is still the same. So I used to ask them like, okay, morning when you get up, what do you take? The patient will say, sir, I will take a SABA. And then when there is an asthma attack, what do you take? The patient will say, sir, I will take a LABA plus ICS. In such case, this will not prevent the attack, and this will not relieve the attack because this is long acting. It will take longer time to start acting. This will not relieve the attack. This will not prevent the attack. So neither attack frequency has come down, and neither once an attack is set in, the medications are helping the patient. But since the advent of this drug called formoterol, the management of asthma has become easier. Why it has become easier? So currently, the preferred treatment for asthma patients is a combination of formoterol plus inhaled corticosteroid. Why is this preferred? Because the formoterol is a rapid onset LABA. Rapid onset LABA. Very, very important point. See, now think about it. Why SABA was my choice for relieving an attack? Because short onset of action. Now I'm short of breath. Take a puff. Quick onset of action. My problem is solved. Right? While LABA was suitable for prevention, morning to evening, it was allowing me to have bronchodilation so that constriction doesn't happen. Now I get both the benefits in single drug because it acts long, so it will be able to prevent. So it can be a maintenance medication, but its onset of action is quick, rapid. So it can also be a reliever. So now your reliever and maintenance medication is rolled into one, which is a combination of formoterol plus inhaled corticosteroid. So now when you look at the current Gina guidelines, it's always about formoterol and steroid combination. Only thing is whether I should use this formoterol steroid combination on a daily basis or as and when required. Just to give you an example, right? Even I am an asthmatic, but the last attack of asthma I had was years ago, literally few years ago. Do you think I should be on an inhaler on a daily basis to prevent one more attack of asthma that may happen years down the line? Of course not, right? On the other hand, I have a patient who gets asthma attack quite often, right? Almost every second day or third day, he is getting an asthma attack. Do you think he needs to be on preventive treatment? Yes, right? So now what is the cutoff? When do you decide that a particular person requires preventive treatment and a particular person can take the inhaler when required? This is the point that helps you to differentiate. Right now, look closely. If asthma patients are having asthma symptoms less than twice a month, means in a month, maybe once or max twice, asthma attack happens. Such patients don't require regular inhalers, right? So they will take only as needed combination of inhaled corticosteroid and formoterol. On the other hand, if the asthma attacks are more frequent, like symptoms on most days, or even nighttime symptoms even once a week, such patients will definitely require preventive treatment. Like every other day I'm getting asthma attack, so it is better to prevent than relieve with a reliever. So for such patients we go for maintenance treatment. Same drug we are using here, also we are using formoterol and inhaled corticosteroid combination, but only as and when required. Here patient will take morning one puff and night one puff, so that it is prevented. Now, same story patient with very low lung function. Now, what do I mean by low lung function? When patient's FEV1 is less than 30% of the predicted value, we will call it as low lung function. Such patients, if I start steroids at low dose, it may not be effective. So we start with the medium dose. Otherwise, we always start with the low dose of steroids. But those whose lung function is very low, we will start them on a medium dose steroid maintenance along with formoterol. Now, the approach is pretty simple. Okay, I will give you an algorithm which will help you to recreate this in the exam in a better way, right? So if you have a patient with asthma, the first thing that you have to ask is whether patient has asthma attacks on most days. Most days in the sense 5 days or more per week. Asthma attacks on most days, right? More than or equal to 5 days per week, or more than or equal to one nocturnal attack, means nighttime asthma attack. This is the question that we always ask a patient with asthma. If you say answer is yes for this question, right, that means the patient requires preventive treatment or maintenance treatment, requires maintenance treatment. And if you say no, sir, patient is getting only once or twice a month asthma attacks, right, then he don't require maintenance treatment. So in such cases, you can say no maintenance treatment required. So for these patients, how do you treat? We will treat them with as and when required, low dose inhaled corticosteroid plus formoterol combination. Why are we using formoterol? Because formoterol is rapid onset LABA. So when there is an attack, because it is rapid onset, it will take care. In the future, if patient requires maintenance, I can continue with the same drug. That's why we will start with this only. Okay. Now, when patient requires maintenance treatment, we will call that treatment as MART. MART stands for maintenance and reliever therapy. Same inhaler will be used for maintenance morning, evening. In between an asthma attack, patient will take the same inhaler. Reliever का काम भी वही कर रहा है, maintenance या prevention का काम भी वही कर रहा है. But if you look at this stepwise approach, right, we learned that in some case we start with low dose, in some case we start with medium dose. So how do I decide? So once we decide that patient requires SMART, we have to look at patient's FEV1. If the FEV1 is less than 30% of predicted, or whether it is more than 30% of predicted value. So if it is less than 30% of predicted value, the patient will be started on medium dose. Low is not enough. Medium dose inhaled corticosteroid plus formoterol combination. And if it is more than 30%, you don't need to start with the medium dose. You will start with the low dose. So we'll start with low dose inhaled corticosteroid plus formoterol combination. This is nothing but an algorithmic approach to this diagram. You can either write this diagram or you can write this algorithm. This algorithm makes it easier for the examiner to take a quick look and give you the necessary marks. Okay. Now the question is, there can be a 3-mark question asking you, how do you manage a patient who is not responding to the medium dose inhaled corticosteroid or formoterol ICS combination? Because when you look at this, we follow a step ladder approach. So if I started with as and when required low dose formoterol and not responding, I will start with maintenance. If I started with low dose maintenance not responding, I will start with medium dose maintenance. If I started here for the first time not responding, then I have to escalate further. So what are the options I have for those who are not responding to medium dose MART? Because initial treatment does not start with step 5, right? When you look at this, this is starting treatment. You can either start here, or start here. Means I can start with as and when required treatment or MART, low dose MART or medium dose MART. I do not start anything higher, right? So what do I do if even after reaching medium dose MART, patient is not controlled? For patients refractory or not responding to medium dose MART, what are the choices I have? So sympathetic system we have already explored, right? We have stimulated the sympathetic, that is beta agonism, with the formoterol. Now what else I have? I can explore the unexplored, that is parasympathetic blockade, right? So I can consider adding LAMA. So one of the choice I have for those patients who are not responding is adding long-acting antimuscarinic agent. Good choice. What else I can do? Now I have new class of drugs called as biologicals. What options we have? I have a drug called as dupilumab. Then we have omalizumab. Then we have benralizumab. I will help you to remember these drugs for the exam, but for now just make a note of it. Dupilumab, omalizumab, benralizumab, reslicumab, and tazepilumab. Okay, and one more drug is there. It is mepolizumab. Okay. So first one, dupilumab is a monoclonal antibody against. It's an anti-interleukin 4 receptor monoclonal antibody. Anti-IL-4 monoclonal antibody. MAP. Omalizumab is an anti-IgE monoclonal antibody. Benralizumab is the anti-interleukin 5 receptor monoclonal antibody. Reslicumab is IL-5 monoclonal antibody. Mepolizumab is also anti-interleukin 5 monoclonal antibody. And tazepilumab is an anti-thymic stromal lymphopoietin monoclonal antibody. These are the list of drugs we have. Okay, now I have a question. In the very beginning, I discussed about this classification of asthma into type 2 and non-type, right? Let us revise it because I want you to write this table in the exam. This is a scoring point because this is what is the talk of the town among physicians when we have difficult to treat asthma cases. Type 2 asthma, what are the cytokines involved? Interleukin 4, interleukin 5 and IgE. And non-type 2, it is interleukin 1 and interleukin 6, right? Okay. Now, can I use this drug called dupilumab for the non-type 2 asthma? No, because remember, I will write it here. In type 2, we have interleukin 5, interleukin 4 and IgE, right? In type 1, what is involved? Interleukin 1 and interleukin 6 and some other inflammatory cytokines. So can I use dupilumab for the type 1? No, right? Can I use omalizumab? No, because IgE is not involved in type 1. right? Can I use benralizumab, reslizumab, or mepolizumab? They are all targeting IL-5, which is not involved in type 1. So majority of these drugs are suitable for suitable for only type 2 asthma. They are not suitable for the non-type 2. So there is only one monoclonal antibody which is suitable for treatment of type 2 asthma, non-type 2 asthma, sorry, that is tazepilumab. So I want you to make it a point to mention that these are for type 2 asthma, and the tazepilumab is the only one for type 1 and type 2 asthma. This is suitable for both type 1 as well as type 2. I told you I will help you to remember it. So now let us try to remember it. How to write which drug is targeting what monoclonal antibody. First point to remember here is D. D is the fourth letter of the alphabet. So that way you can remember that dupilumab is anti-IL-4. Okay. Then tazepilumab, T for thymic stromal lymphopoietin or TSLP. Okay. Omalizumab, E and O are very close in the alphabetical order, right? So that way you can remember that omalizumab is anti-Ig. Whatever is left is anti-IL-5. T for T, tazepilumab for anti-TSLP. D fourth letter, anti-interleukin 4. O and E alphabetically closely related. So omalizumab is anti-IgE. Rest all are interleukin 5. Okay. One point, specific point. Which monoclonal antibody is suitable for treatment of type 1 asthma? Sorry, I should not call it as type 1. The non-type 2 asthma. The one that is suitable for non-type 2 asthma is tazepilumab. Can it be used for type 2 also? Yes. So everything is suitable for type 2, but only tazepilumab is for non-type 2. Okay. So now this is the approach to asthma. You make a diagnosis with PFT. You decide the initial treatment based on this algorithm that we have written. For that, what information I need? How many attacks happen per week, right? Whether most of the days or less frequent. That will decide whether I should give maintenance or as and when required. And if patient requires maintenance, whether I should start with a lower dose or medium dose, that will be decided by patient's FEV1. Okay. Once I initiate the treatment, if the patient is not controlled, I will step up. If I started here, I'll go here. If I started here, I'll go here. If I had started here, that is medium dose MART, and still not controlled, my choices are I can either add long-acting antimuscarinic agent like tiotropium, or I can use biologicals. Okay. So that is about the management of asthma. Okay. Now, what else they can ask? They can add a 5-mark or a 3-mark component. How will you manage acute severe asthma? Now, what is acute severe asthma? Conceptually, it is simple. Patient's asthma attack which is not responding to optimal dose of steroids and beta agonist. This is a simple definition. If you are able to remember more complicated definition, well and good. Otherwise, conceptually, what is it? It is an asthma attack. Asthma attack not responding to optimal dosage of repeated administration of bronchodilators and steroids. Like you get a patient with asthma, he's going through an attack, I give multiple nebs of bronchodilators and steroids, he is not settling down. That is my acute severe asthma. This is a simplistic definition. Even if you write this much, it's more than adequate. But a more complex definition given by Gina says that an acute severe asthma is a patient who is not able to talk in sentences. He talks in words only because he's so short of breath that he is not able to complete a sentence. He's like, sir, I am feeling short of breath. He's talking in words. He leans forward, he's agitated because of hypoxia. He's using accessory muscles of respiration to make the oxygen levels satisfactory. Respiratory rate is more than 30, heart rate is more than 20, and saturation on room air is less than 90%, and the peak expiratory flow rate is less than 50% of patient's best. If you can write this, good. If not, this is also acceptable definition of acute severe asthma. What examiner will be asking you, how will you manage this? How do we manage acute severe asthma? So of course, when you look at this, you know that patient will be hypoxic, right? So when we have a patient with acute severe asthma, start administering oxygen. Try to maintain saturation of 95% or higher. And then we have to start giving short-acting beta agonists like salbutamol or albuterol in the form of nebulization. Dose is not important in an undergraduate exam. If you can remember, good. Otherwise, dose is not important. The frequency of administration is important. Every 20 minutes, you keep giving a short-acting beta agonist, preferably in a nebulized form. If nebulizer is not available, 4 to 8 puffs of whatever meter dose inhaler the patient has. Like for example, ipratropium. Along with that, we are also giving, remember, what have we written as a definition? Bronchodilators and steroids. So we are also giving 100 milligrams of hydrocortisone IV. So I give one shot of hydrocortisone. I give a nebulization or a meter dose inhaler, 4 to 8 puffs every 20 minutes. And despite all of this, if patient is not settling down, I will reassess at 1 hour with patient's peak expiratory flow rate and saturation. If I have not achieved this, that means patient is going down the hill. If I have not achieved this, then what is the next step? The next step is to administer magnesium sulfate. If anybody asks you, what is the initial treatment of choice for acute severe asthma, right? Initial treatment of acute severe asthma is short-acting beta agonist, right? That is the initial treatment, right? If there is, that is what we have just discussed. If there is failure, then what is the drug of choice? When there is failure of short-acting beta agonist in relieving acute severe asthma, in that case, we come to IV magnesium sulfate. Where else do we use magnesium sulfate? Magnesium sulfate has membrane stabilizing properties. For this reason, we have used it. Basically, it causes smooth muscle relaxation by stabilizing the membrane. So we do use it in patients with hypertensive emergencies, like for example, pregnancy-induced hypertension, that is eclampsia, preeclampsia. We also use it in the status epilepticus because it has membrane stabilizing properties. For the same reason, we can also use it in asthma. Okay. Now, if the magnesium sulfate also fails, in that case, it is very difficult to make this patient survive because he will not be able to maintain the saturation low. In such cases, we have to start them on non-invasive ventilation, that is your BiPAP. And if that does not help, eventually we have to intubate and ventilate till the asthma attack suffices. So in writing this algorithm, the points I want you to mention is first, basic stabilization, give the oxygen target saturation 75% and start administering SABA. SABA every 20 minutes. Q stands for every 20 minutes, right? At the end of 1 hour, means you would have done roughly 3 to 4 rounds of SABA and patient is not showing response, then it is failure. In that case, IV magnesium sulfate. If that also goes into failure, patient continues to be in severe asthma. In that case, we go for ventilatory support. Ventilatory support. This is the simplistic algorithm that you can write in the exam. If you can reproduce this, well and good. If not, at least this much you should be able to write. So that completes our discussion of asthma. Okay, so if you have any questions regarding asthma, we will address it and then we will take up the next question. So when you type your queries, let me quickly re-summarize what we should write on a 10 marks or a 20 mark question on asthma. Definition, 2 words to focus, small airways, reversible obstruction. Clinical features, anyway, that is standard for all your respiratory diseases, shortness of breath and cough. Here we are adding one, wheeze. Okay. Triggers, few important triggers you should remember, mainly allergen, cold air, then airway irritants, drugs like aspirin and beta blockers. Then in terms of investigations or the diagnosis, you don't have to write everything about the diagnosis like chest x-ray, sputum culture, analysis, all that is not required. Just mention that the investigation of choice is PFT In the PFT, what we are interested, FEV1 by FVC ratio. If it is less than 0.7, we will think of obstructive disorder. And for confirmation that it is asthma, we do bronchodilator reversibility test. We give a short-acting beta agonist inhalation and recheck FEV1. If it increases by more than 12%, then it is asthma. What additional tests are available? We have fractional exhalation of nitric oxide and methacholine challenge test. Types of asthma, you should remember intrinsic versus extrinsic table, as well as type 2 versus non-type 2. These itself can be 3 marks question. Discuss different types of asthma, or compare type 2 and non-type 2 asthma, or compare intrinsic versus extrinsic asthma. And then management of asthma. This can be a 5 mark question. Write briefly about the management of asthma according to current Gina guidelines. 5 mark question, or it can be part of a long question on asthma. So what I want you to write here, mention the drugs available, this classification, the concept of a reliever and maintenance medication, and then the Gina approach. For the Gina approach, either you can recreate this step ladder pattern, or you can recreate the flow chart that we have created here. This flow chart is more easy to recreate and eye pleasing for the examiner. If they ask you how do you manage a refractory asthma, you can mention these drugs. And then management of acute severe asthma. This itself can be 3 or 5 mark question. So at least have a conceptual definition or the Gina definition. After that, this management algorithm. 3 steps mainly. Start with SABA every 20 minutes. 1 hour later, no response, magnesium sulfate, no response, intubation. Okay. So that completes our questions on asthma. We will go to the next 10 mark question, which is about interstitial lung diseases. This is the same question that has appeared in many university papers. Classify ILDs. Examiners generally give 2 marks for the classification of ILDs if it is a 10 mark question. And then describe diagnosis and management of 2 subtypes of ILDs, idiopathic pulmonary fibrosis and idiopathic non-specific interstitial pneumonia. So they will give 3 marks for idiopathic non-specific interstitial pneumonia, and they will give around 5 marks for the idiopathic pulmonary. This is the usual split. As I've already told you, any question which is for 10 marks, even if they're not asking the definition, begin with the definition. So what is the definition of interstitial lung disease? Interstitial lung disease, the point to mention here is that it is a group of disorders. It's not a single disease, not like asthma. It's a group of disorders which share some common features. What are those common features? Inflammation and or fibrosis of the lung interstitium. What is interstitium? The connective tissue that surrounds the alveoli, airway and blood vessels. If the connective tissue is impaired, it will of course impair the functioning of the alveoli, and there will be impaired gas exchange, and thus it leads to restrictive lung pathology. So asthma and COPD are obstructive disorder. ILDs are restrictive disorder. So there are 2 important points you should mention in the definition, even if you're not able to recreate this. First one, that these are a group of disorders characterized by inflammation and or fibrosis of lung interstitium. Second point, these are restrictive lung disorders. 2 points, more than enough. So the point number 1 is this, and the point number 2 is this is restrictive lung disorders. Okay. After that, we will talk about the classification. I'll give you a book classification and a more simpler classification that you can write in the exam. This is the book classification. How is it classified as? ILDs are classified into ILDs of known cause, where a interstitial lung disease has a known cause. For example, connective tissue disorder associated ILDs. Example is rheumatoid arthritis. A lot of them develop ILD. It is a connective tissue disorder related ILD, right? Then drugs, mainly anti-cancer drugs, like for example, methotrexate, right? Methotrexate, bleomycin. These are the drugs which are known to cause ILD. You can mention 1 or 2 of those names. Okay. Then genetic causes are there. For example, you might have seen this Amitabh Bachchan's movie called Pa, right, where he had progeria. Those patients, it is a genetic disorder. They also have ILD. And then environmental exposures. For example, asbestosis, silicosis. Right? Examples you can quote is asbestosis, silicosis. These are all ILDs of known cause. Here we know a cause, right? Rheumatoid arthritis is a known cause. methotrexate, bleomycin, known cause. Asbestos exposure, silica exposure, coal workers pneumoconiosis, known cause, right? These are idiopathic. We will call them as idiopathic interstitial pneumonias. So under that we have idiopathic pulmonary fibrosis or IPF. Then we have idiopathic non-specific interstitial pneumonia or NSIP. These are the two most important types. Apart from that, rare variants like acute interstitial pneumonia, respiratory bronchiolitis associated ILD, cryptogenic organizing pneumonia, desquamative interstitial pneumonia, then lymphocytic interstitial pneumonia. The list is long. What I want you to write here, IPF and NSIP, you should not miss under this heading of idiopathic interstitial pneumonias. Then we have granulomatous disease. Again, I am reiterating what is the definition. These are disorders where there is either inflammation or fibrosis of the connective tissue of the lungs. It may be idiopathic or via known cause. Right. So among those known causes, it can be infections. Tuberculosis can cause. Fungal infections like cryptococcus can cause. And sarcoidosis, right? These are the conditions where we have granulomatous inflammation. And then some rare or miscellaneous entities like eosinophilic granulomatosis with polyangiitis, EGPA, or eosinophilic pneumonia. No need to follow this table if you find it difficult to remember. I'll give you a more simpler way which you can replicate in the examination easily. So more alternate way of classification of interstitial lung diseases. Broadly, we will classify the interstitial lung diseases into two groups. ILDs of known cause, where the cause is clearly known, and ILDs of unknown cause. ILDs of unknown cause. Okay. Among the known cause, first thing that you should mention is connective tissue disorder related ILDs, CTD ILDs, which include diseases like rheumatoid arthritis, which is a connective tissue disorder, or the SLE, then scleroderma. All these patients are known to develop interstitial lung disease. Okay. Where the cause is known, rheumatoid arthritis as a cause or SLE as a cause is known. Second, pneumoconiosis, where there is occupational exposure to some substances like asbestosis, which is a known cause. Asbestosis, coal workers pneumoconiosis, or silicosis, these are all known cause, right? Or hypersensitivity pneumonitis, these are all known cause. Okay. Then third you can mention here is granulomatous diseases. One example you should mention is sarcoidosis, where what causes sarcoidosis we don't know, but sarcoidosis, once it causes ILD, the ILD becomes of a known cause. Now among the ILDs of unknown cause, we will classify them into three broad groups. The first one is idiopathic pulmonary fibrosis or IPF. Second one is non-specific interstitial pneumonia or NSIP. The third one is your smoking related ILDs. Now what do I mean by that? In these cases, smoking has a strong association with these ILDs, but that does not mean that smoking is the sole cause. So we won't count them as ILDs of known cause. We know that smoking is a risk factor. In these cases, we clearly know that sarcoidosis has led to ILD, or rheumatoid arthritis has led to ILD, or asbestos exposure has led to ILD. That's why we will be classifying them as ILDs of known cause. So what comes under this smoking related ILDs? First thing you should mention is respiratory bronchiolitis ILD. Respiratory bronchiolitis ILD or RBILD. Second one is desquamative interstitial pneumonia or DIP, desquamative interstitial pneumonia or DIP. The third one, pulmonary Langerhans cell histiocytosis or PLCH, pulmonary Langerhans cell histiocytosis. This is more than enough classification for the examiners, for your prof exam. For your MCQ based exam, definitely yes, this table is more important. But for the prof exam, if they ask you to write about classification of IELTS, this is more than enough. If you want to just extend this classification, we can write one more saying miscellaneous, which covers anything else we have not covered. It all will come under this miscellaneous. Like eosinophilic pneumonia, everything will come under that. This is a very simple and easy to remember also, right? Known cause, unknown cause. Under unknown cause, wherever we are using the word idiopathic, definitely they will come into picture. Idiopathic pulmonary fibrosis, idiopathic non-specific interstitial pneumonia, and smoking related IITs. Once we have written about the classification, these are the two things that examiners want you to write. So we'll start with idiopathic pulmonary fibrosis first. What points you should write about? If it is a general heading like write about idiopathic pulmonary fibrosis, the approach is very simple, right? You should write about the cause. The cause is known. Of course, this is idiopathic. The cause is not known. When the cause is not known, we should write the risk factors if they are known. Risk factors, clinical features, diagnosis, and management. Same about the NSIP. Risk factors, clinical features, diagnosis, and management. So we'll start with the risk factors for idiopathic pulmonary fibrosis. One point I want you to mention even before you write about the risk factors in the exam is this is the most common type of ILD. So among all ILDs that we have listed in the classification, this is the most common. We will be covering all the systems. This is the most common ILD. Write this just to please the examiner. And then start with the risk factors. Now, what are the risk factors? The risk factors, the first one is about age, gender, whether there is any relationship with the smoking, and whether there is any relationship with the genetics. So remember, age-wise, it is more common in people who are more than 55 years of age. You don't see a kid presenting with idiopathic pulmonary fibrosis, quite rare. Gender-wise, male gender is unfortunate. It is more common in males than females. And typically, it is more common in smokers. And genetic-wise, there are two mutations which are responsible. Mutations in a gene called as MUC5B. If you remember, it's okay. Otherwise, you can just skip it. Mutation in MUC5B and mutation in telomere regulators. There are a lot of genes which regulate the telomeres. If there is mutation in telomere regulators, that can also increase your risk of developing idiopathic pulmonary fibrosis. In fact, mutation in telomere regulators itself was responsible for a disease called progeria, which is the center point of story of this movie called Farre. So progeria, whole body is aging faster because we're not able to maintain the telomere length. So even the lungs are aging faster and there is fibrosis of the lungs. Okay. So can I say in simple words that ILD, that is idiopathic pulmonary fibrosis, is a typical disease of an elderly male who had been smoking for several years. If I make that statement, is that true looking at the risk factor? Yes, most of your patients are going to be elderly males who had a long history of smoking. Important, I am reiterating, you have to remember this to compare it with the NSIP. Comparison makes it remember things better. Right? Okay. Now, what clinical features these patients will present with? What is it going to be? Of course, cough, shortness of breath. For all respiratory system symptoms, this is what you will be writing. Shortness of breath, or you can write it as dyspnea and cough. These are the symptoms that you are expecting in these patients. Okay. Now, on examination, what findings I'm going to get? If I auscultate a patient with the COPD or asthma, there is bronchoconstriction. Air is passing through a narrow airway. It will produce musical sound, which we will call as wheeze. But here, it is the connective tissue which is getting affected, not the airway. So we will not have wheeze. So what auscultatory findings we are going to get? The auscultatory finding that we are going to get will be described as crackles. We will describe them as Fine means crackles or crepitations are described as fine and coarse. What is the difference between fine and coarse crepitations? Fine crepitations resemble opening of a velcro, like those ladies' purse which will have a velcro and you open it, it opens with that is the fine crepitations. If you take a straw, put it in a glass filled with water and try to blow air into it, that is our coarse crepitations. So here we are going to get fine crepitations which are mainly heard at the end of inspiration. Fine and inspiratory crepitations. Inspiratory crepitations. These are described as, because they are fine, they can be described as, remember this word is very important, examiner will be looking for it. This will be described as velcro crackles because it resembles opening of a velcro zip of the pouch. Please mention this word, velcro crackles. This is what pleases the examiner and makes him give you the adequate marks for it. Okay. If you want a visual representation, you can also write that. Like you can say this is inspiration, and this is expiration, and in the inspiration, towards the end of inspiration, there will be crackles. So this is the inspiratory sound, this is the expiratory sound, and towards the end of inspiration you have these crackles. That's just a visual representation of these sounds that we are hearing, and we are going to call it as velcro crackles. Okay. So with this, I have a clinical suspicion that when I got an elderly male who had been smoking all his life, he has come with shortness of breath and cough. And when I heard his chest, if I had heard these, I would have thought of COPD, but I heard velcro crackles. Now I will think of idiopathic pulmonary fibrosis. So I have to now go to diagnosis. So for diagnosis, what will be the investigation of choice? The investigation of choice for diagnosis is not chest X-ray because the fibrosis is not easily visible on the chest X-ray. So what are we going to do? We are going to do HRCT. HRCT is the investigation of choice. And what findings we are going to get on the HRCT? The findings that we are going to get on the HRCT, first thing you should write is reticular opacities. Remember here the lungs are fibrosed. Fibrosis is what? Fibrosis. We will be completing all the systems. So what is fibrosis? Abnormal excess deposition of collagen. That is the basic concept of fibrosis. When you say this particular tissue is fibrous, means more than required amount of abnormal collagen is deposited. So when those collagens are deposited as fibers or threads, right, they will be visible as reticular opacities. Reticular opacities. Okay. Along with that, so let us say that this is one bronchial tree, right? This is one bronchial tree. Now the surrounding connective tissue is going to fibrose, right? It is becoming stiff. So it will pull this airway in different directions depending on how much the tissue is getting fibrous. So the airway is being pulled. When the airway is being pulled, it will become dilated. When airway becomes irreversibly dilated, we call it as bronchiectasis, right? Irreversible dilatation of bronchi is called as bronchiectasis. So here it is because of the traction of the fibrosed tissue. We will call it as traction bronchiectasis. Traction bronchiectasis. That is the second finding. And when too many of these bronchi dilate under this traction, they are getting dilated, right? So when they become dilated, they become all these cystic spaces. And now when I look at the whole lung, it is filled with this dilated bronchi. And the whole lung, because of too many dilated bronchi, may start looking like the honeycomb. So in that case, we will call it as honeycomb appearance. Honeycomb appearance. I could have easily shown you a CT image, but I'm not bringing that into the Farre series because you can't recreate a CT image in the examination. So we'll focus on what we can write in the examination rather than what is required for our understanding. So these are the 3 points you have to write, that there will be reticular opacities, traction bronchiectasis, and honeycomb appearance. And these changes collectively we call it as usual interstitial pneumonia pattern, UIP pattern. So HRCT in idiopathic pulmonary fibrosis shows UIP pattern. So whenever a radiologist reports it as UIP pattern in a context of elderly male with a smoking history presenting with cough and shortness of breath and Velcro patterns, we have our diagnosis done. Okay. But if examiner asks you, or if you have a 10-mark question and you need to write more, you can also write about PFT. PFT is not the investigation of choice, but it will help you to differentiate it from COPD because your patient is going to be a smoker. So in PFT, what are we going to get? We are going to get restrictive pattern. Now, what restrictive pattern means? We will be looking at patients FEV1, FVC, and FEV1 by FVC ratio. So what happens here? Patient's forced vital capacity will be decreased. Why? Because the lung is fibrosed. So we can't take too much air into the lungs. So the amount of air I can take or amount of air I can throw out is reduced. So my FVC will be decreased. And if my FVC is decreased, the amount of air what I'm taking in itself is less. So the amount of air that I will be throwing out in 1 second, that is FEV1, that will also be less. Because if I take less in, I throw less out. It's as simple as that. So even FEV1 will be reduced. And because FEV1 and FVC both are proportionately reduced, the ratio will remain normal. What is the ratio? Normal ratio more than 0.7. If one of them decreases more than the other, the ratio will get altered. But both are proportionately decreased, so the ratio will be normal. This is what we call as the restrictive pattern on the PFT. So PFT will show restrictive pattern and HRCT will show UIP. So with that, the diagnosis is done. Once I have done the diagnosis, next is the management. Whenever you write about management, if you are aware of the prognosis, write one sentence about it before you start writing about the management. Now, idiopathic pulmonary fibrosis carries poor prognosis. Many of these patients will not be able to survive beyond 3 to 5 years after the diagnosis. So mention the point that it carries poor prognosis. You don't have to write the numbers, but at least mention that it carries poor prognosis. Okay. So how do I manage? It's a disease where there is fibrosis. So we try to manage them with first line management is anti-fibrotic agents that inhibit the fibrosis. Anti-fibrotic agents. I want you to write 2 anti-fibrotic agents which inhibit fibroblasts. Remember, fibrosis is done by fibroblasts. Who deposits the connective tissue in our body? Fibroblasts, right? They become overactive, deposit abnormal, higher amount of collagen, and that is our fibrosis. So their activity can be inhibited by 2 drugs. The first one is pirfenidone. And the second one is a tyrosine kinase inhibitor that also reduces the activity of fibroblast. We will call it as nintedanib. These 2 agents are anti-fibrotic. That is first line. Second line treatment. Remember, fibroblasts are also similar to blood cells. So they can also be inhibited by the immunosuppressants. So second line treatment will be immunosuppressants. And when I say immunosuppressants, it can be corticosteroids or it can be azathioprine or it can be mycophenolate mofetil or MMF, cyclosporine as well as cyclophosphamide. You can write 2 or 3 immunosuppressants under this heading. Okay, that is our second line. And if patient continues to prognose, because we have already told that this carries poor prognosis, so what will I use as the third line management if patient continues to progress? Third line management is lung transplantation. So if patients do not respond to even immunosuppressants, then we don't have any choice. Find a suitable brain dead lung donor and do the lung transplantation. Practically very difficult to get the right donor, but that's the last choice if immunosuppressants also fail, which is the most common scenario. Most patients will eventually progress through the stages. We will start with antifibrotics, few months, few years, chal jayega. Then we have to initiate immunosuppressants, few months, few years, chal jayega. Eventually, We will ask them to find a donor for lung transplantation. If they find, well and good, otherwise it will lead to patient's death. Okay. Now you should also mention the causes for death in patients with idiopathic pulmonary fibrosis. The first cause is related to hypoxia or respiratory failure. Because lungs are fibrous, you're not able to maintain the oxygen levels, so that can lead to. And the second cause can be because of the lung disease, we can develop pulmonary hypertension, and pulmonary hypertension can lead to right heart failure, that can also lead to death. And when lung disorders lead to right heart failure, what do we call it as? We call it as cor pulmonale. Cor pulmonale. This is about our idiopathic pulmonary fibrosis. On the similar line, we have one more idiopathic interstitial lung disease, which is called as NSIP, which stands for idiopathic. It is also idiopathic. Idiopathic non-specific interstitial pneumonitis or pneumonia. Okay. So of course it is idiopathic. So we will start with the risk factors itself. Now when it comes to risk factors, remember, I have already told you when we spoke about idiopathic pulmonary fibrosis that I want you to remember these 3 points: age, gender, and smoking history. Idiopathic pulmonary fibrosis is more common among elderly, males, smokers. You write exactly opposite of it as risk factors for the non-specific interstitial pneumonia. Non-specific interstitial pneumonia. So in terms of age, it is more common in young. IPF, elderly. So age less than 40 years. In terms of gender, this is more common in IPF was more common in males. This is more common in females. And with respect to smoking history increase the risk of IPF. Here it is protective. So it is more common among non-smokers. So in simple words, right, many of my audience right now are females. Just think about it. If you are young, you are female and you don't smoke, you are at risk of developing idiopathic non-specific interstitial pneumonia. So if you want to avoid the risk, what should you do? These are the 3 variables you can handle, right? One, you should age faster, go beyond 40, your risk comes down, or the gender switch, or start smoking. That reduces the risk. Of course, I'm not recommending you to start smoking, but just to remember, female young who does not smoke is at risk of developing NSI. Okay. Now, these patients will present with what clinical features? They will also present with same symptoms. What is that? Shortness of breath and cough. In all respiratory disorders, it is same. Whether it is pleural effusion, pneumothorax, whether it is pleuritis, whether it is pulmonary embolism, this is the same symptom: shortness of breath and cough. On examination, what do I get? On examination, again, I will get fine and inspiratory crackles, same as idiopathic pulmonary fibrosis. Then how will I differentiate it from the idiopathic pulmonary fibrosis? It is the investigations that are going to help me to differentiate. So for here also, investigation of choice is going to be HRCT. And what HRCT findings I will be seeing? Instead of getting the traction bronchiectasis and honeycomb changes, what findings I will get? I will get something called as ground glass opacities. Now what do I mean by ground glass opacities? These are the opacities which are not fully opaque, not fully translucent, somewhat in between, through which bronchi and blood vessels are visible. This opacity, not everything is white, opaque, like somewhat gray, and bronchi and blood vessels are visible through it. So it is, you can say, semi-opaque. That's why it is called as ground glass opacities. So findings, mainly you have to write extensive ground glass opacities. And this pattern is called by radiologists as NSIP pattern. By radiologists, this is called as NSIP pattern. Okay, so if you have a patient who is having fine crepitations, is a female, young, non-smoker, you can suspect NSIP, ask for HRCT, and the radiologist reports that this is NSIP pattern. you are more or less leaning towards the diagnosis of idiopathic NSIP. Now, once you have diagnosed it, right, how will you manage? The management here is relatively more simple. They have excellent response to steroids. So first line management will be short course oral corticosteroids. Most of them will respond well. And if they don't, then second line, as usual, we will go with immunosuppressants, right? You don't have to write the list again because above we have already mentioned the list of immunosuppressants that are available with us. Second line. In idiopathic NSIP, you don't have to write the third line, that is lung transplantation, because most of these patients do not require lung transplantation. These patients respond very well to either steroids or immunosuppressants, right? So in comparison, like if you want to close it beautifully, you can write a small comparison between NSIP and the idiopathic pulmonary fibrosis, right? Demographics. First thing you will mention is demographics. So typically, idiopathic pulmonary fibrosis is more common in elderly males who have history of smokers, right? NSIP is more common in young non-smoking females. It's more common in young non-smoking females. So the radiographic findings or HRCT findings, this will show UIP pattern. Mainly what it covers? Mainly it includes traction bronchiectasis and honeycomb changes. Traction bronchiectasis. The fibrous tissue is pulling the bronchi in different direction, causing dilatation of them. And too many dilatation, the whole lung will start looking like honeycomb. Honeycomb is the word that you need to mention. Honeycomb changes. And then in this you get NSIP pattern, which is characterized by what is called as ground glass opacities. Ground glass opacities. Third point I want you to mention is the prognosis. Who carries good prognosis? The good prognosis is seen in patients with NSIP, and the prognosis is poor in patients with idiopathic pulmonary fibrosis. So this is a decent visual representation of the points that we have discussed above. If you have less time, you are not able to write all the things that we discussed, at least put this table. Mostly you will get at least half of the marks that examiner intends to give you. Aniket Tiga, see, Kumar and Clark is a very beautifully written book. The problem is not with the book. It's a very, very good book. But if you're able to read it and understand, for your understanding, it is good. But unfortunately, most of our examiners who set your university papers or who set your MCQ-based papers for NEET PG or the INI PG, INI CET, they literally follow Harrison. So it is more likely that the verbatim lines from Harrison are picked up. So when you are able to recall that, it is better. So I would still suggest that if you want to follow a textbook, just to please our examiners, follow Harrison. But for understanding, Kumar and Clark is a very beautiful book. Okay, so that is about our idiopathic pulmonary fibrosis. Okay, so to give you a quick summary, what you need to write, you need to be able to write the definition. 2 points to mention in the definition is it is the inflammation or fibrosis of interstitium and it is a restrictive disorder. Second thing, classification, just remember this and vomit it out in the exam paper, more than enough. Known cause, unknown cause, under unknown cause, IPF, NSIP, smoking related and miscellaneous. Then IPF risk factors, mainly remember age, gender, smoking, same opposite of it for NSIP. Complaint wise, you will write shortness of breath and cough both cases. You will write the same examination finding, that is Velcro crackles in both cases, IPF as well as NSIP. Difference comes in HRCT findings. Here UIP pattern, honeycomb is the word to remember. There it is the ground glass opacities or NSIP pattern. Management wise, here we have first line anti-fibrotics, then immunosuppressants, and then lung transplantation. And for the NSIP, it is the steroids and immunosuppressants, no anti-fibrotics, no lung transplantation. You don't have to write about it. Okay. Now coming to the next topic, which is COPD. What kind of questions can be asked? There can be a broad question for 10 marks on the COPD. They may just ask you to write everything related to COPD, definition, diagnosis, types, classification, diagnostic approach, management algorithm, everything, or they will subcategorize and define COPD and then discuss the differences between the emphysema and chronic bronchitis or the clinical features of emphysema and chronic bronchitis, write about diagnosis and write about management. So if it is a 10-mark question, how the marks will be split? They will give you usually 2 marks for the definition, then 3 marks for the comparison between emphysema and chronic bronchitis, and then 5 marks for the diagnosis and management. Out of that, 2 marks for diagnosis and 3 marks for the management of COPD. These can be again individually clubbed, like write about the diagnosis and management of COPD for 5 marks. Right? So we'll begin with the definition. What is COPD? Always remember and compare it with asthma when you are writing. Asthma is also an obstructive disorder. COPD is also an obstructive disorder, right? So try to bring the differences between asthma and COPD in your definition. So how I will define it as? I will define it as a chronic obstructive respiratory disorder. So first thing I'm mentioning here is that I'm using the word obstructive. And here we have a clearly established cause due to chronic exposure. Exposure to what? Don't write smoking directly. Chronic exposure to, I will use the term noxious, the damaging gases, because smoking is not the only cause. Due to chronic exposure to noxious gases characterized by, because I have to also differentiate it from asthma, that is also an obstructive disorder, characterized by persistent obstruction, characterized by persistent obstruction. So this is the second point that should be part of your definition. It is an obstructive disorder, but it is not reversible like asthma. It is persistent, and I'm also making it sure that there is exposure to noxious gases. We will discuss more about that in a minute. Okay. Then we will go to the listing of subtypes of COPD, which examiner has already mentioned, emphysema and chronic bronchitis. So we have 2 subtypes. The first one is emphysema. What is expected from you in the examination hall? A clear-cut definition of what is emphysema. What is emphysema? How do I define it? Emphysema is defined as irreversible. First word is very important, irreversible dilatation and destruction of what? More precise word to use is not alveoli, but acini. Irreversible dilatation and destruction of acini. Now, what do I mean by acini? Right? Those who don't know, just a quick recap of what is acini. We know that the airway goes on dividing. Trachea becomes right and left main bronchi. They will further divide through generations. Then eventually we enter a part which is called as respiratory bronchiole. The part before this is called as terminal bronchiole. This respiratory bronchiole generally divides into multiple alveolar ducts. We will call them as alveolar ducts. And these alveolar ducts lead to alveolar sacs or alveoli. Now, what is acinus? Acinus refers to one respiratory bronchiole plus all of its alveolar ducts and alveoli, like as a unit, right? Think of it like a flower. This is a small stem of the flower and all the petals. Everything put together, we call it as acini. So when these acini become irreversibly dilated, it can be dilatation of respiratory bronchiole or alveolar ducts or alveoli or everything. Then we will call it as emphysema, right? So if you want, you can write acini is equal to what? One acini is equal to one respiratory bronchiole plus all of its alveolar ducts and alveoli. and alveoli. That is our acinus, singular acinus. Okay. Now this emphysema we have already defined. So when these parts become irreversibly dilated, we will call it as emphysema. Okay. Now the dilatation may only affect respiratory bronchiole or whole of the alveoli, whole of the acini, or only the alveoli. So based on what is being affected, we will call them as panacinar, centriacinar, and distal acinar. So subtypes of emphysema are there. Subtypes of emphysema. So what are the subtypes of emphysema? The first one, the most common one, is centriacinar. Centriacinar. So what happens in centriacinar? In the centriacinar, only the respiratory bronchiole gets dilated. Only the respiratory bronchiole gets dilated. So in centriacinar, because the center of the acinus is this respiratory bronchiole. So when only the respiratory bronchiole gets dilated, we will call it as centriacinar. Okay, that is one type. Then I have panacinar. In panacinar, the whole of the acinus is dilated, as we know from the name itself. So in panacinar, whole of the acinus gets dilated. So here the dilatation is going to affect every structure. So in panacinar, everything, the respiratory bronchiole, alveolar ducts as well as alveoli are dilated. That is panacinar. And then we have the third one, which is called as distal or paraseptal. Distal, also called as paraseptal, where primarily alveoli are dilated. Means the respiratory bronchiole is unaffected, alveolar ducts are unaffected. It is only the alveoli which are dilated. So only alveoli end up becoming irreversibly dilated. Then it is distal or paraseptal. Dilatation is restricted to only these portions. So when whole of the acinus is dilated, it is panacinar. Okay. You are expected to write the causes. Centriacinar is usually smoking related. It is smoking. Centriacinar is smoking related. Panacinar is due to alpha-1 antitrypsin deficiency. Okay. The distal or paraseptal, where it can form bullae and it can rupture and cause pneumothorax, can be without any other causes, like without smoking. It can be seen in young individuals who are especially thin and tall, who are more prone to develop spontaneous pneumothorax. But it can also be caused by smoking. Important points you should be mentioning is the causes for the centriacinar and panacinar. Okay. So this is the basic concept of emphysema. Irreversible dilatation and destruction of acini. Subtypes are centriacinar, where only respiratory bronchiole, the center of acinus is dilated, whole acinus dilated. Panacinar. Panacinar is alpha-1 antitrypsin deficiency. Okay. Now in the exam, it is better if you write, because smoking can cause COPD, alpha-1 antitrypsin can also cause COPD. You should be able to write the difference between the emphysema caused by smoking and emphysema caused by alpha-1 antitrypsin deficiency. So emphysema due to smoking and emphysema due to alpha-1 antitrypsin deficiency. Okay, so we'll try to put a table comparing these 2 points. The first one, cause. As we already know, emphysema, the pattern. As we already know, the smoking related emphysema is centriacinar. Centriacinar. And alpha-1 antitrypsin deficiency is panacinar. Second, distribution. Which lobes are mainly affected? Remember, in the smoking related emphysema, upper lobes are more affected than the lower lobes. On the other hand, in the alpha-1 antitrypsin deficiency, lower lobes are more affected than the upper lobes. Now, how do I remember this stuff easily? Okay. So all you have to do is think of it. Think of a smoker. Right? Why people smoke? People smoke to feel high, right? High. When they have a puff of cigarette, they feel like they are out of this world, right? They are on cloud nine. They feel high. High is upper lobes, right? So to feel high, you smoke, so upper lobes. If I tell you that you are suffering from a genetic disease, alpha-1 antitrypsin deficiency is a genetic diagnosis, right? If you're suffering from a genetic disease, how do you feel? You feel very low. So that way you can remember that lower lobes are more affected. Now, how do I remember centriacinar versus panacinar? Okay, just think of your close friend who smokes. Of course, I know you have at least one close friend who smokes, right? Now, think of his behavior in the classrooms, right? After every one or two class, he will be restless because he wants to go out and have a puff. उनके दिमाग का सेंटर थॉट क्या चल रहा है हमेशा? Smoking, right? So a smoker's center of thought is always smoking. So that way you can remember centriacinar is smoking. Centriacinar is smoking. And whatever is left panacinar is for alpha-1 antitrypsin deficiency. So this is our basic introduction to emphysema. We have done the definition, we have described the types. Now we have to describe the clinical features of emphysema part of COPD. Clinical features of emphysema part of COPD. Now I will just take few minutes for you to understand things better so that you can write it in the exam in your own words. Okay. I will ask you one basic question. And before answering that, before even asking that question, right, let me tell you two important rules of physics. One of the rule is called as Boyle's law. What Boyle's law says, take any chamber, like I'm holding this bottle, pressure inside this bottle now is inversely proportionate to its volume. So if I decrease the volume, right, by squeezing it, what will happen to the pressure inside it? Increase. Or if I dilate it, the pressure inside it will decrease. So pressure of a chamber is inversely proportionate to its volume. And the second thing you have to remember is air and fluid, right, move from higher pressure to lower pressure zone, right? From higher pressure to lower pressure zone. Two things you have to remember. Okay. Now think about a patient with emphysema, right? So this is his trachea, bronchi, they go into lungs, and inside the lungs, his acini are dilated, whether it is centriacinar, panacinar, it doesn't matter. The acini is dilated. Dilated means what happened to the volume? Volume is increased. So when volume increases, what happens to pressure inside the alveoli? Volume is increased. Pressure decreases, right? So these patients' alveolar pressure is decreased. And what the second law says? Air and fluid move from higher to lower pressure zone. So now atmospheric pressure is high during inspiration. Your alveolar pressure is very low because it is already dilated. So comfortably air will come into it. So air came into the alveolar. Now if I have to send the air out from alveoli, what happens? What should happen to the pressure inside the alveoli in comparison to atmospheric pressure? If air has to come out from my alveoli to the atmosphere, the pressure inside the alveoli should be higher than that of atmosphere. Only then the air will leave. But will I be able to achieve that higher pressure inside the alveoli if I have emphysema? Remember, normal alveoli expands, recoils. Here it is irreversibly dilated. That's why we are using the word irreversible. Dilated, वापस नहीं जाएगा. So if it is not able to recoil, it remains in dilated form. Pressure inside the alveoli is never going to become high. So air that comes to alveoli, low pressure air will come, but it will not be able to leave. So air keeps coming into this alveoli, keeps dilating it more, keeps coming. This is what we call as air trapping. So air is getting trapped in the alveoli, patient is not able to exhale it. So patient will start now struggling to exhale. So when he is struggling to exhale, he will try to make some modifications in his breathing pattern, which will help him to build more pressure inside the alveoli. What is that? Now think about it, right? This opening. If he, while exhaling, if he makes it narrow, right? What will happen to the pressure inside the airway if the opening of the airway becomes narrow? Pressure will increase or decrease? Like this bottle, right? I'm trying to exhale by squeezing it and I keep the opening very small. What will happen to pressure inside? Increases. If I keep the opening wide, what will happen to pressure inside it? Decreases, right? So what these patients will do now, because for them to drive out the air from this air that is trapped in this emphysematous alveoli, they have to increase the pressure inside the airway. So for that, they will make the mouth opening small. What we call that as pursed lip breathing. Pursed lip breathing, right? Okay, that is one compensatory mechanism. So that if the lip becomes pursed, more pressure builds up, and as we know, air moves from higher to lower pressure. So if the airway pressure is high, then it will move to atmosphere. Okay, that is one. But of course, how much it can compensate? It has a limit, right? So beyond that limitation, what happens? Alveoli will get flooded with air, they start dilating, and the lungs will start increasing in size. As the lungs start increasing in size, thorax cannot expand horizontally, it will start expanding antero-posteriorly. So antero-posterior diameter now starts increasing. Why the thorax cannot expand horizontally? Because the ribs are anteriorly and posteriorly attached. You can't stretch them horizontally. But their angle of inclination can be changed to increase the antero-posterior diameter. So lungs expand antero-posteriorly. That gives rise to what we call as barrel-shaped chest. So two things you should always mention in a patient with emphysema. In terms of symptom, they have difficulty to exhale. Air easily goes into the alveoli because alveoli are dilated, their pressure is low. But because their pressure is low, air stays there only, it doesn't come out easily. So that will definitely lead to shortness of breath or dyspnea. The struggle is more for exhalation, and to compensate for that, they will have something called as pursed lip breathing. Pursed lip breathing. Please mention how it helps to the patient. It helps by increasing PEEP. What is PEEP? Positive end expiratory pressure. Basically, airway pressure, it is increasing. Okay. Then third, they will have increased antero-posterior thoracic diameter, increased antero-posterior thoracic diameter because of the expanding lungs, and that gives rise to what we call as barrel-shaped chest. Barrel-shaped chest. You can definitely write a small sketch here to give a visual representation. Normally, our horizontal diameter is more than antero-posterior. So you can write little elliptical picture like this as normal. This you can say as the transverse diameter. Transverse diameter, and this you can write it as antero-posterior. This is the normal chest. But in these patients, the antero-posterior diameter is increased, so it almost looks like a barrel. There is increase in the antero-posterior diameter in comparison to transverse diameter, and this is what we call as barrel-shaped chest. So these are the two important clinical features of emphysema that you should mention. Okay. Now you should also mention that these patients of emphysema are also called as pink puffers, right? They are also known as pink puffers. Why are they called as pink puffers? They're called as pink because they're not sinused. Why they're not sinused? Because they're able to take the air in. Their alveoli are at lower pressure. Air is coming into the lungs. So oxygen is coming. They're not able to exhale. Right? So hypoxia is not happening. So they are not having cyanosis. They are not going to be blue. But why are we calling them as puffers? Because their lungs are getting puffed. The air is getting trapped into the lungs. The lungs are expanding. So the lungs are becoming like your nicely puffed veg puffs or puffed corns. That's why it is called as pink puffers. And that's why we are having this barrel-shaped chest. This is about the emphysema. Okay. Now, chronic bronchitis. The second subtype is chronic bronchitis. First we have discussed, we will go to the second, which is chronic bronchitis. Chronic bronchitis. So these patients with chronic bronchitis are also called as, they are also known as Blue bloaters. Why are they called as blue bloaters? Because these tend to be cyanosed. We will understand why they are going to be cyanosed. They're called as blue bloaters. It is because of cyanosis. Okay. Now we have to write the definition of chronic bronchitis. How do I define chronic bronchitis? Please remember the definition that I followed for the emphysema. It's more of pathological or anatomical definition, right? I said that some structure in the lung is dilated. But the definition that I'm going to follow for the chronic bronchitis is a clinical definition. It's not pathological definition, right? How do I define it as productive? What do I mean by productive? Productive refers to with sputum. Productive means with sputum. Productive cough for more than or equal to 3 months per year. 3 months per year for 2 consecutive years. Very, very important. This is a very objective definition. So any patient with history of smoking, if he presents with cough for at least 3 months in a year, like let us say we're talking about 2024. So in 2024, he had cough, let me say in November, January, like November, December, and maybe February, 3 months in 2024. Now in 2025 also another 3 months, like let us say Jan, Feb, and July he had cough. So 3 months last year, 3 months this year. And these 2 years are consecutive, means 24, 25, not a gap year in between. Then we will call it as chronic bronchitis. 2 successive years, each year at least 3 months of cough with sputum production. In a patient with background history of smoking, we will call it as chronic bronchitis. So here what happens? There is inflammation of the airway. So when airway becomes inflamed, it becomes narrow. Like let us say this is the airway. When it becomes inflamed, it is narrowed. And this will of course lead to a lot of persistent modifications like fibrosis and all. And because of that, this narrowing is irreversible. So now you have persistent airway obstruction. So it will limit the oxygen airflow. And also the gas exchange at the level of alveoli because of inflammation will be restricted. So these patients will become hypoxic. And because they have hypoxia, they will become cyanous, right? So in terms of clinical features, what these patients present with? Clinical features wise, a patient with chronic bronchitis present with productive cough, that is cough with sputum production. These patients can also have dyspnea. They can have cyanosis due to hypoxia, and they often have edema due to heart failure. Why these patients are going to heart failure is a very detailed discussion. Today, let us not waste the time. I'll give you just a gist of it, just for understanding. Now, if some alveoli in the lungs are not getting sufficient air, what body tries to do is the capillaries around those alveoli go into constriction. Why they go into constriction? Like let us say this is one alveoli in the lung, right? Around it, I have a capillary. This capillary brings the blood from the right side of the heart through what we call as pulmonary artery and takes the blood to left side of the heart through what we call as pulmonary vein. Okay. Now, if this alveoli doesn't get oxygen, then the blood that came to this alveoli will go to the left side of the heart without getting oxygenated. Do we want that? Of course not. So what body will do? It will constrict this capillary so that this deoxygenated or the alveoli which is not ventilated does not participate in the breathing process. But because of this constriction, pressure inside the pulmonary artery starts increasing. So I now got pulmonary hypertension. Pulmonary artery pressure is high. That will lead to increase in the right ventricular pressure and eventually right ventricle will fail. So it started with pulmonary vasoconstriction, ended with right heart failure. This is again what we call as cor pulmonale. So patients with chronic bronchitis are more prone for cor pulmonale. And that is why these are called as blue bloaters. They are bloated, their body is bloated with fluid. These patients with chronic emphysema, they have less likelihood of developing heart failure. Their lungs are puffed, filled with air. Here it is bloated, means filled with fluid. Their body is filled with fluid. So these are the clinical features that you should mention for chronic bronchitis. Okay, you can definitely put a comparison table between the two conditions. The emphysema is because of the air trapping. The mechanism I have already described from the perspective of physics. The chronic bronchitis, there is airway inflammation and mucus hypersecretion. These patients will have productive cough. These patients will have mainly shortness of breath or dyspnea. Here, pursed lip breathing and barrel-shaped chest. Here, cyanosis and edema because of heart failure. Okay. Now, PFT findings. I will discuss that later when we go to diagnosis. Okay. After that, you can definitely fill it in the table. Now, imaging, whether I do chest X-ray or HRCT, here I will see lung hyperinflation and formation of bullae, those inflated alveoli. Here we will see the inflamed bronchi will show prominent peribronchiovascular markings because the bronchi are inflamed. This is a table that summarizes the differences between emphysema and chronic bronchitis. Of course, mention chronic bronchitis is called as blue bloaters and emphysema patients are called as pink puffers. And as long as you remember this, that kind of summarizes, right? Pink puffers, lungs are puffed. Why? Because air trapping. Why air trapping happens? Because alveoli are irreversibly dilated. Blue bloaters, blue because sinus, because airway is inflamed, it has become narrow. And why bloaters? Because the narrow airway hypoventilation of the alveoli leads to pulmonary vasoconstriction, eventually right heart failure, so they will develop edema. That's why we are calling them as bloaters. Okay, so now we know the subtypes of COPD and how to differentiate between the two. Now comes the question of diagnosis of COPD. What is the investigation of choice for diagnosis of COPD? COPD is also diagnosed based on PFT. PFT. Investigation of choice for diagnosis of COPD is PFT. So what are we going to get in the PFT? We will get obstructive pattern. Obstructive pattern. What is obstructive pattern? The FEV1 by FVC ratio will be less than 0.7. That is our obstructive pattern. Does that confirm it is COPD? Of course. Right. So then what is the next step? Because obstructive pattern means asthma also possible. Right. I have to differentiate that. So how do I differentiate? After this, I have to do what is called as bronchodilator reversibility test. I have to administer a short-acting beta agonist. And if I get less than 12% increase in FEV1, then it could be COPD, right? It is suggestive of persistent obstruction, and then definitely you can think of possibility of COPD in those patients. If it is showing more than 12% increase in FEV1, it is irreversible obstruction, and then we will think of asthma. Okay. What additional investigations we can do for the diagnosis of COPD? Additional investigations. Not routinely required, but what else we can do? Yes, here chest X-ray has a role because emphysema can be diagnosed based on chest X-ray, right? Second, we can do something called as DLCO. Okay, I'll come to the DLCO, but before that, chest X-ray. Chest X-ray will show emphysema easily. How? Because the lungs are getting expanded. So what findings we will get? Hyperinflation. Lungs are bigger. Hyperinflation of the lungs. And when lungs become hyperinflated, what will happen to the rib spaces? They will become wide because lungs are becoming enlarged. Rib spaces will become stretched wide. So wide rib spaces. Okay. What else will happen? As the lungs expand, they will push the diaphragm down. So normally when you look at the chest X-ray, you notice that there are two domes of the diaphragm. One right slightly higher because of the presence of liver, and one left dome slightly lower, but there is a dome, right? So this is right dome of diaphragm. This is left dome of diaphragm. But once the lungs become hyperinflated, they will push it down and the diaphragm will become flattened. So this is normal to have the domes of the liver. But when it gets pushed down, right, it will become flattened. So when it becomes flattened like this, then we will say it is suggestive of emphysema. So flattened dome of diaphragm. You are not able to recognize the dome shape. This will be flattened dome. So that is another finding that you can get, flattened dome of diaphragm. So these are the X-ray findings. If you remember, good. If you can't remember, it's absolutely fine as long as you're able to write about the PFT diagnosis of COPD, because diagnosis is always made with the help of PFT and not with the X-ray or other investigations. This is just for scoring some extra points. Okay. Now the next thing is DLCO. What is DLCO? DLCO stands for diffusing capacity of the lung for carbon monoxide. Means how much carbon monoxide can pass through the alveoli to blood. We ask the patient to inhale carbon monoxide and then we will check it in the blood in the form of carboxyhemoglobin. What it tests? It tests the ability of the alveoli to allow the diffusion of gases. If alveoli are good, they will allow the diffusion of gases, and carbon monoxide in the blood will be good, means normal, after we give inhaled carbon monoxide. But if alveoli are damaged, they will not allow the diffusion because they are damaged. So in COPD, are alveoli damaged? Yes. In emphysema, acini are dilated. Acini are part of, like alveoli are part of acini. So because of that, there can be alveolar damage, and that can lead to decrease in the DLCO. Decrease in the DLCO in emphysema variant. In chronic bronchitis, the bronchi are inflamed, alveoli are not damaged, so you will not have decrease in the DLCO. Right? That is the point that this table mentioned. You will have reduced DLCO in emphysema because alveoli are irreversibly damaged and the carbon monoxide diffuses through alveoli. If alveoli are damaged, it cannot diffuse. Here alveoli are not affected, so there is no diffusion. But airflow is limited because there is obstruction. And here there is increased residual volume because more and more air is going into the lungs. It is not leaving the lungs, so it is staying in the lung only. That is why residual volume is increased. Okay. Now that summarizes our diagnosis of COPD, chronic bronchitis and emphysema. What are the key points you should write and how to define the COPD. Now comes the management. Now in the management, either you can simply write, if you don't have time, the drugs available and leave it at that. You will, instead of 3 marks, you will get 1 or 1.5 marks. If you have time, then write how the gold guidelines recommend for the management of COPD. So there is a stepwise approach. The first step is grading the severity of COPD. Grading the severity of COPD. So COPD is graded into grade 1, 2, 3 and 4. What is it based on? It is based on post bronchodilator reversibility test, FEV1. Means we would have done this bronchodilator reversibility test and we have checked the FEV1, right? So whatever FEV1 we are getting based on that. Okay. So if FEV1 is more than or equal to 80%, FEV1 is more than or equal to 80%, then it is grade 1. And if it is less than 30%, it is grade 4. Okay. Then if it is 30 to 50%, it is grade 3, and 50 to 80%, it is grade 2. Right. So the best way to remember this is that write down more than 80% as grade 1 and less than 30% as grade 2. 30% is the important number in respiratory system. Remember, we have spoken about asthma and I have given you an algorithm to write for initial management of asthma, right? When to decide MART and when to decide as and when required inhalation therapy, right? So remember this, we are taking 30% FEV1 as the number. If it is less than 30%, we are starting with medium dose medication. So 30 is a very important number in respiratory. So in COPD also for grading FEV1, we are using 30% here, right? Less than 30% is grade 4. And if it is more than 80%, grade 1, 30 to 50, 50 to 80 is grade 2 and grade 3 respectively. So this is COPD grading. COPD grading does not influence the initial management. But still, why we need to write or why we need to know? Because sometimes examiners specifically ask, describe the grading of COPD. Why is it done as a first step? This is mainly done for assessing the prognosis. Means, let us say I got a patient whose FEV1 after giving a bronchodilator is 20%. Now I start him on some treatment and I see him for follow-up. And during the follow-up, from 20%, FEV1 has now become 60%. So am I on the right track? Yes, FEV1 is improving, right? The grade 4 has become grade 2. That means patient is responding. Like this is helping us to assess the response to treatment. On the other hand, let us say I got a patient whose FEV1 was 60%. I start treatment. When he comes back for follow-up, it is now 25%. Means he is not responding. My treatment is not on the right. So this is primarily used for assessing the response to treatment, not for deciding the initial treatment. So how do I decide the initial management? So first we will, just like asthma, we will mention the drugs used for COPD treatment. Okay. So what all drugs I can use? I can use long-acting beta agonists and long-acting anti-muscarinic agents. These are the main drugs that are used for COPD patients, right? Then we are using them as bronchodilators. Okay. What else I can use? I can also use corticosteroids to reduce the inflammation. I can use mucolytics because there is increased sputum production in chronic bronchitis patients. I can use mucolytics. What else I can use for a treatment of COPD patient? We have a phosphodiesterase 4 inhibitor called as roflumilast, which is a phosphodiesterase 4 inhibitor. Okay. What else we can use? We can also use azithromycin. I will come to this. Why are we using azithromycin for COPD patients? But we can think of that's one of the choices. Okay. What else we have? Okay, let me label it instead of drugs. Let me say treatment, because apart from that, what else we can do? We can give them something called as LTOT, which stands for long-term oxygen therapy, which stands for long-term oxygen therapy. We can give oxygen to the patient. We can also do a surgery called as LVRS, which stands for lung volume reduction surgery. Lung volume reduction surgery. So these are the choices. Now, if I write this much, I'll get 1 marks. Now to get 2 more marks for the management of COPD, I should be able to write the approach. How do I start the treatment? And for non-responders, what do I do? Right? So for that approach, we have something called as gold guidelines. Okay, I forgot to mention one more thing. For COPD patients, we also recommend certain vaccines. You should be able to write what vaccines are recommended. Mainly, it is the pneumococcal vaccine, then influenza vaccine, COVID-19 vaccine, and pertussis vaccine. These are the vaccines that are recommended for a patient with COPD. Okay. Now coming to the main thing. How do I initially start the treatment for COPD patients? We have already known grading of COPD, right? Grade 1, 2, 3, 4 based on FEV1. Less than 30%, grade 4. More than 80%, grade 1, right? 30 to 50, 50 to 80, right? Grade 3, grade 2, respectively. That is not going to decide the management. This is only for assessing the response to treatment or prognosis. Management is decided based on categorization of the patients. So I will give you an approach that you can easily replicate in the exam. So what gold guidelines say is, if patient had more than or equal to 2 moderate exacerbations. Exacerbation means worsening of COPD. Exacerbations in past 1 year, or more than or equal to 1 hospitalization in past 1 year. This is the information that we need from the patient, and this is exactly how I want you to write in the examination. Book it may be very difficult theory sentences, but always try to convert it into a visual representation for better assessment by the examiner and getting better marks for ourselves. Okay, so now either patient had this like 1 admission last year, or 2 moderate exacerbation last year, or he did not have no admission, no more than or equal to 2 moderate exacerbation. If you say yes, right, then that patient will be put into a category called as category E. Category E. E for exacerbation. Remember, E for exacerbation. What history I am looking at? I am looking at exacerbation. So this patient's main problem is frequent exacerbation. Exacerbation that required him to get admitted, or exacerbation that is severe enough to be considered as moderate, 2 or more than that in last 1 year. So we'll call it as category E, or exacerbation predominant. Okay. Now for such patients, how do we treat? Initial treatment. How do I treat? Okay. Now remember, I have told you 2 drugs as bronchodilators, LABA and LAMA. If given a choice, what will you prefer for a patient with COPD? For asthma, we always preferred LABA, right? Because LABA is a stronger bronchodilator. Stimulating beta receptors causes more bronchodilation than blocking the muscarinic receptor. But generally in pharmacology books, they mention LAMA as the drug of choice for COPD. Why? Because LAMA has an important advantage. So we are talking about exacerbation here, right? Why they have exacerbations? Is it because they suddenly started smoking more? No, many of them cut down on smoking once they're diagnosed with COPD. May quit also. And why do they have exacerbation? The most common cause for exacerbations is infections, respiratory infections. Why infections are more common in COPD patients? Because in pathology, you study that COPD is associated with goblet cell hyperplasia, means there is increased mucus production. In other words, increased sputum production. And sputum can act as a culture media for bacteria, right? Bacteria can comfortably replicate in your sputum. So if I have to reduce the infection, what should I do? Because infection is the cause for exacerbation, right? More the infection, more is the exacerbation. So if I have to cut this chain, right? And the infections are more because of increased mucus production. There is a chain here. So if I have to cut down the exacerbation, I have to cut down the infection. If I have to cut down the infection, I should also cut down the mucus production. And remember the side effects of atropine. Atropine decreases the secretions, right? On the other hand, acetylcholine increases the secretions. So atropine causes dryness everywhere, right? Mouth dryness, tongue dryness, throat dryness, even constipation, dryness everywhere because it inhibits the secretions. And what is LAMA? Right, LAMA is nothing but an atropine category of drugs. So they inhibit mucus production. So by inhibiting mucus production, we decrease the infection rate. By decreasing the infection rate, we reduce the exacerbation. So LAMA not only causes bronchodilation but decreases mucus production and indirectly help you to reduce exacerbation. That is why it is the preferred drug for COPD. But of course, nowadays we want to give the best treatment to patient. So in addition to LAMA, here we will also treat them with LABA for better bronchodilation. So we treat them with a combination of LAMA plus LABA. Okay, I hope that is clear. And why are we giving vaccines to these patients? Because again, same thing, infections contribute to exacerbation. So at least those infections where vaccines can prevent, we will use it, right? Okay. Now, if exacerbations are not a big problem, right, then he will not go into category E. We have 2 more categories. We will call them as category A and category B. Now, if you are wondering why is it not category A, B and C, just to have a mental connect that E stands for exacerbation, we have called it as category E. We could have called it as category C, but we call it as category E so that we remember this is a patient who is having frequent exacerbations requiring admissions or hospital visits. But if not, then he should go into category A or B. Now, how will I decide whether he should go into category A or category B? For that, we have to look at patient's dyspnea or the shortness of breath grade. Dyspnea grade using Modified Medical Research Council grading, MMRC grading. If let us say it is MMRC's shortness of breath grade is 0 to 4. 0 means no shortness of breath. 4 is so short of breath that patient cannot come out of his bed, restricted to his room or bed. It's grade 4. Right. So if it is grade 0 to 1, or if it is more than or equal to 2, If it is more than or equal to 2, right, that patient will be put into category B. And if it is 0 to 1, that patient will be put into category A. Now, how do I treat category B patients? These patients will be treated with again LAMA plus LABA combination. Same as category E, no difference. Only thing is that we know these patients' main problem is shortness of breath, grade is high, not exacerbation. These patients, neither shortness of breath is major problem, nor exacerbation is major problem. So for such patients, we don't need to treat them with two drugs. So you can treat them with either LAMA or LABA. Given a choice, I will definitely choose LAMA over LABA in COPD patients, but you are free to choose any of them. But for B and E, it is always combination of LAMA plus LABA. This is the gold guideline approach. Okay. Now, what if I have started with LAMA and LABA and patient is not responding? That is the last thing that I want you to write. For patients refractory to LAMA plus LABA, what I can do. So for those who are not responding to LAMA and LABA, what choices you have? One, you can add inhaled corticosteroids. Means the treatment combination will be LAMA plus LABA plus inhaled corticosteroids with the hope that it will reduce the inflammation. But it is not suitable for all patients, right? Only if patient's eosinophil count is more than or equal to 300 per cubic millimeter. If eosinophil count is not high, steroids will not be able to do much because eosinophils are not involved in inflammation. Okay. Second drug that we can use is roflumilast. Roflumilast. What is roflumilast? It is a phosphodiesterase 4 inhibitor. You have to write its mechanism. That is what examiner will be looking for, not just the name of the drug. It's a phosphodiesterase 4 inhibitor. So by inhibiting the phosphodiesterase 4, it will increase the nitric oxide levels and they will cause bronchodilation. And the third thing that we can consider in patients who are not responding to LAMA plus LABA is adding azithromycin. If you are thinking, sir, azithromycin will reduce infection, no. That is not the main reason why we are using it. We all know that macrolides are abused left, right, and center, and most of the bacteria out in the society are resistant to macrolides. You go to pharmacy, say, I have throat, he will give you azithromycin, right? We are not using here primarily for its antibiotic property, but because it also has anti-inflammatory property. So it can reduce the chronic bronchitis. It has anti-inflammatory properties. Right? This is how we manage a COPD. Right? Now we know how to start initial treatment. Right? This is the initial treatment. Whether you want to start LAMA alone or LABA alone or LAMA plus LABA based on the category. After that, if they are not responding, these are the choices you can have. So that completes our discussion of COPD, right? Again, quick recap of the points that we have discussed. We have learned how to define COPD, 2 points, obstructive and persistent. Then emphysema, chronic bronchitis. Under emphysema, I want you to define it as irreversible dilatation and destruction of acini, not use the term alveolar, instead acini, and then describe whether it is centriacinar, panacinar or distal and what are the causes, and put a table comparing smoking versus alpha-1 antitrypsin deficiency as a cause for emphysema. Mention these pink puffers and blue bloaters for emphysema, chronic bronchitis. Mention the pursed lip breathing and the barrel shaped chest. If you can put an image, well and good. Even if you can write a human image with the barrel shaped chest, well appreciated by the examiners. Need not be a perfect sketch. For chronic bronchitis, don't forget to mention blue bloaters. And if you can elaborate why they are called blue bloaters. Blue because of cyanosis, bloaters because of heart failure and edema. Put the objective definition, very, very important. You should not get confused between months and years. 3 months per year for 2 consecutive years. Okay. Describe the clinical features. Put a table describing the differences between emphysema and chronic bronchitis. And then when it comes to diagnosis, please write down the algorithm using the PFT. Obstructive pattern and then bronchodilator reversibility test. Chest X-ray. If you have time, write about the emphysema findings and the role of DLCO. In the management, first is grading, second is initial management, third thing, talk about refractory treatment when patients are not responding to initial management. In the grading, mention the grades. In the initial management, write down this algorithm, and then after that mention the management of refractory cases. So that completes our COPD. So we'll take 10 more minutes today. We will talk one more topic, which is especially from southern universities like universities in Karnataka, Tamil Nadu, repeatedly asked question, which is on pulmonary hypertension. We could have discussed this in cardiology also, but because our Farre booklet contains it in respiratory, we will address it here only. The question they ask usually is define or the diagnostic criteria for pulmonary hypertension, which will carry 2 marks. Then they will ask you to write a short note on pulmonary arterial hypertension, which will carry 3 marks. So it can be a 5-mark question. Okay. Or they can try to make it as 10-mark question, where they will ask you define pulmonary hypertension, then 3 marks for the different types of pulmonary hypertension or classification of pulmonary hypertension, then the diagnosis of pulmonary arterial hypertension for 2 marks, and then 3 marks for the management of pulmonary arterial hypertension. It can be expanded to 10 marks. We'll try to cover both ways, 10 marks or 5 marks. What is pulmonary hypertension? Systemic hypertension, we are familiar, right? So first we will begin by understanding what is BP. What is BP? If I have a blood vessel, right? This is my blood vessel. What is BP? When the blood moves through this, right? Let us say blood is moving through the blood vessel. When a blood is moving through it, it is exerting lateral pressure on the walls of the blood vessel. Lateral pressure exerted by the column of blood on the walls of the blood pressure is called as BP, right? Blood pressure. Assure like assure. So it will be called as BP. Now, when this BP gets increased in the systemic blood vessel, that is the blood vessels coming from aorta and its branches, we will call it a systemic hypertension. On the other hand, right side of the heart, there is a blood vessel which connects right ventricle to lungs, that is pulmonary artery. If the pressure there increases, then we will call it as pulmonary hypertension. This is a basic concept. Okay. But the objective definition of pulmonary hypertension is not that. But anyway, we will write both. First, we will write this is the increased blood pressure in pulmonary artery. It's a simple concept. Now, the objective definition, like systemic hypertension, we say more than or equal to 140 systolic or 90 diastolic is our systemic hypertension. So here, I have to use it for the pulmonary artery. But pulmonary artery, unfortunately, we cannot rely too much on the diastolic BP. So instead of that, we use the mean pressure, not the systolic different and diastolic different. So criteria for diagnosing the pulmonary hypertension is mean pulmonary artery pressure. MPAP refers to mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. If you are following older editions of the standard textbook, be it Davidson, Kumaran, Clark or Harrison, they mentioned 25. But from 2024, it has been revised to 20 millimeters of mercury. Why? Because even patients with the pulmonary artery pressure more than 20 millimeters of mercury are at higher risk of death. So now we have revised. This is the cutoff. So this is the criteria. Mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. Okay. So we'll try to understand in 2 minutes the concept of it. So we know that we have a right side of the heart, right? We have a right ventricle. We have right atrium, right ventricle, and from the right ventricle, a pulmonary artery divides into 2 for the right and left lungs. Right, for this, the pictorial understanding, I will take one lung into consideration. Once this artery enters the lung, of course, divides through several branches. Ultimately, it goes to form capillaries, right? Capillaries around the alveoli. So let us say this is an alveoli. It forms a capillaries around it. In the capillaries, the blood gets oxygenated, and then it goes to the oxygenated blood goes to the left side of the heart through what we call as pulmonary veins, right? It will go to the left atrium through pulmonary veins. It will go to left atrium. From there, it will go to left ventricle, and from the left ventricle, we will eject it out through aorta. This is a basic arrangement. Now, elevation in the pressure in this artery is what we call as pulmonary hypertension, right? So if it is more than or equal to 20 millimeters, mean pulmonary artery pressure more than or equal to 20 millimeters of mercury is my pulmonary hypertension. Now, what all can cause it? Okay. So if the pulmonary capillaries are constricted, can it cause? Yes, if pulmonary capillaries constrict, for me to pass the blood across this constricted capillaries, I have to increase the pressure inside the pulmonary artery. Only then blood will pass through this constricted pulmonary capillary. So it will increase. Okay. So it can be because of pulmonary capillary constriction. Pulmonary capillaries can get constricted if less amount of oxygen is coming to the alveoli. Means a problem of the lungs can make the pulmonary capillaries to get constricted. That can indirectly cause elevation in the pressure. One problem. So lung problems can be a reason. Okay. Can heart problem be a reason for elevation in the pulmonary artery pressure? Of course, yes. How? Because if I have some left ventricular failure or mitral stenosis, in that case, the left atrial pressure will increase. So if the left atrial pressure increases, now for me to drain the blood from the capillaries to pulmonary veins, from the pulmonary veins to left atrium, the pressure in the pulmonary veins has to be higher than the left atrium, right? Only then the blood will come. So pulmonary vein pressure has to increase. So once the pulmonary vein pressure increases, it has to be higher than the left atrium, right? Higher than the left atrium. Now for the blood to drain from capillaries to pulmonary veins, the pressure inside the capillaries has to be higher than the pulmonary veins. So now a left heart problem resulted in left atrial pressure increase, pulmonary vein pressure increase, eventually pulmonary capillary increase. Now for me to pass the blood from pulmonary artery into capillaries, the pressure inside the pulmonary artery has to go higher than the pulmonary capillaries. Only then blood can go, because we know that fluid moves from higher pressure to lower. Until and unless the pressure here is higher, it will not go to capillaries, right? Until and unless the capillary pressure is higher than the pulmonary veins, it will not go to pulmonary veins. So it all started in the left and ended up with the pulmonary hypertension. So heart diseases can also cause pulmonary hypertension. The third thing that can cause the pulmonary hypertension is the constriction of the pulmonary artery. If artery constricts, pressure inside it will increase by Boyle's law, right? Pressure and volume are inversely related. So if volume decreases, pressure will increase. So pulmonary hypertension can be caused by left heart disease, lung disease and artery disease. So based on where is the source or where is the problem, WHO has classified the pulmonary hypertension into different categories. So if the lung disorders are causing pulmonary hypertension, it is one type. If heart disease is causing, it is one type. So there is a WHO classification of pulmonary hypertension. In group 1, we have put pulmonary arterial hypertension. The term pulmonary hypertension is not equal to pulmonary arterial hypertension. So remember it. pH is not equal to PAH. PAH refers to problem inside the pulmonary artery. Means it's not because of lung problem. It's not because of heart problem. Pulmonary artery itself is getting constricted. Then we will call it as pulmonary arterial hypertension. That is group 1. In group 2, right, we have pulmonary hypertension due to heart disease, left heart disease. So if left heart is the problem, if this is a problem, right, it will go into group 2, right? If the pulmonary artery itself is the problem, means if the pulmonary artery itself is a problem, the pathology is in it, then it will go into group 1. Group 1. Group 1 is also called as pulmonary arterial hypertension. Most exam questions ask you to write short note on pulmonary arterial hypertension. So the point you should mention is pulmonary arterial hypertension is pulmonary hypertension in the absence of heart and lung diseases. So when lung diseases become the reason for pulmonary hypertension, it becomes group 3. So if lung is the problem, then it is group 3. It is group 3. Lung diseases is group 3. We have 2 more groups. The 4th group is chronic blood clots in the lungs. Means in these capillaries that I am talking about, if there is a thromboembolism, like a clot forms in the DVT, comes to right atrium, right ventricle, goes to pulmonary artery, and then starts accumulating in these capillaries, eventually that will cause pressure build up in the pulmonary artery. We will call it as group 4. Group 4 is chronic thromboembolic pulmonary hypertension. Okay. The last one is idiopathic, where you are not able to figure out whether it is because of heart disease, lung disease, or idiopathic pulmonary arterial hypertension, right? So these are the groups. So what you should remember, lungs is group 3, heart is group 2, idiopathic or the pulmonary artery itself as a problem is group 1, thromboembolism is group 4, and all miscellaneous or unknown causes is group 5. You have to remember this group to get those 1 or 2 marks. Okay. Now specifically what they will ask you to write short note on pulmonary arterial hypertension. So we'll just spend 5 more minutes on pulmonary arterial hypertension. So what it refers to? It refers to pulmonary hypertension in the absence of heart disease, that is left heart disease, and lung diseases Okay, so basically it is put under WHO group 1. So any patient who does not have any problem with the lungs, any problem with the heart, but his mean pulmonary artery pressure is more than or equal to 20 millimeters of mercury, he will be called as pulmonary arterial hypertension. We are referring to artery as a problem, not lung and heart. Okay. Now what can cause it? Causes, right? It can be idiopathic. Most cases it is idiopathic. You will not be able to identify any cause, right? This is more common. It is most common. And idiopathic is typically more common in females. Then what else can cause it? Second thing that can cause pulmonary arterial hypertension is a connective tissue disorder called as scleroderma. To be more precise, it is the limited cutaneous variant of scleroderma. This is the second most common cause for pulmonary arterial hypertension. Okay. What other causes are known to cause? Drugs. Okay. Drugs and HIV. HIV infection is becoming increasingly recognized as a cause for pulmonary arterial hypertension. These are the causes. Okay. Now, what clinical features these patients will present to me? The clinical features that these patients will present with. Because pulmonary artery pressure is high, right? What changes it will lead to? Now, just think of this image. Pulmonary artery pressure is high. Now, if I have to push the blood from right ventricle to pulmonary artery, do I need more effort or less effort? Pressure in the artery is already high, right? Now I need to generate more pressure in the ventricle, only then blood will go to artery, right? Pressure in the ventricle has to be higher than that of artery. Artery pressure is already high, so ventricular pressure I have to take much higher. So there is increase in the ventricular work. So whenever a muscle works more, it will develop hypertrophy, right? So I can develop right ventricular hypertrophy. That is one change. So because of the hypertrophy, I can have the parasternal heave on examination. That is one change. The second thing is, if I'm not able to get sufficient pressure in the ventricle and not able to pump blood into the pulmonary artery, then the perfusion of the alveoli will decrease, right? If less blood goes to alveoli, less blood gets oxygenated and go to the left side of the heart, I will start developing hypoxia and it will lead to dyspnea. So clinical features wise, the most common symptom that these patients present with is dyspnea or shortness of breath. Dyspnea or shortness of breath. Okay. And on examination, what findings I can get? Examination wise, first thing I can notice is pulmonary artery hypertension leads to loud P2, right? P2 can become loud. The P2 is due to closure of the pulmonic wall. P2 can become loud. Second thing, there can be parasternal heave because the right ventricle is hypertrophied. Whenever a large muscular chamber contracts, right, externally, we can feel that contraction. We will call it as heave, parasternal heave due to right ventricular hypertrophy. Eventually, patients can develop right ventricle, hypertrophied right ventricle will start dilating. Dilatation leads to tricuspid regurgitation, right? May have tricuspid regurgitation, which has a systolic murmur. In the last FMG exam that was just concluded, there was a story of a patient with pulmonary hypertension who presented with systolic murmur. What do you suspect? So basically, hypertrophied right ventricle eventually starts dilating. So dilatation dilates the tricuspid valve also, resulting in regurgitation. So that is one more thing that we should be aware of. Now comes the diagnosis. Diagnosis. How will we make a diagnosis of pulmonary arterial hypertension? The investigation of choice is not echocardiography. Why? Because echocardiography can only measure the systolic pressure, right? Screening can be done with echo, two-dimensional echo, which will show increased pulmonary artery systolic pressure. We can only measure the systolic pressure from the pulmonary artery. We cannot measure the diastolic pressure. But definition of pulmonary hypertension takes into account mean. So for mean, I also need diastolic mean, right? So that is why I have to put a catheter or the manometer directly into the pulmonary artery and measure the pressure. We will call it as right heart catheterization. Right heart catheterization is the investigation of choice. Right heart catheterization. Okay. And what it should show? More than mean pulmonary artery pressure, more than or equal to 20 millimeters of mercury. Rule out lung and heart diseases. Lung and heart diseases. Then only you can say it is pulmonary arterial hypertension. Okay. So once you're diagnosed, how do you manage? Management of pulmonary arterial hypertension. Remember, it is also associated with poor prognosis. Many patients will not be able to live for few years after the diagnosis. So I have to treat them efficiently. How can I treat? How do we treat systemic hypertension? Systemic BP, we try to reduce by giving drugs which can either deal with the pathophysiology involved or they cause vasodilatation. For example, like systemic BP, we use calcium channel blockers, right? For systemic BP, calcium channel blockers. Why? They cause vasodilatation, right? What else we use? We use AC inhibitors or ARBs, right? Or diuretics. Why we use AC inhibitors or ARBs? Because there is something which is upregulated, a hormonal mechanism that is increased, which is called as RAS. So we want to block this angiotensin activity. So you can say that systemic hypertension means increased RAS activity. Pulmonary arterial hypertension means there is also increased activity of one more neuromodulator, which is endothelin. So we have a choice of blocking the endothelin or using the vasodilator, just like systemic hypertension. So drugs available for treatment of pulmonary arterial hypertension. First one, calcium channel blockers. They act as vasodilators. Vasodilators I can use, right? Second one, endothelin 1 receptor blockers. Because endothelin 1 is causing pulmonary artery vasoconstriction. Angiotensin is causing your systemic vasoconstriction. Endothelin is causing pulmonary artery vasoconstriction. So examples for this, examples for calcium channel blockers I can give are, mainly we are using the dihydropyridine type of calcium channel blockers like amlodipine. Remember, dihydropyridine calcium channel blockers end with dipine. Dipine means dihydropyridine. Then endothelin 1 receptor blockers, we have ambrisentan. They end with sentan. Ambrisentan and bosentan. Bosentan is readily available in India. I have used it for plenty of patients with decent results. These are endothelin 1 receptor blockers. Okay. What else I can do? I want vasodilatation, right? I can also achieve better vasodilatation by increasing nitric oxide. Okay. And nitric oxide production is inhibited by phosphodiesterase 5. So I can also inhibit phosphodiesterase 5. Phosphodiesterase 5 inhibitors. Example, all of us are familiar, like your the sildenafil, which is commonly known as Viagra. Sildenafil, tadalafil. And then prostaglandins also cause vasodilatation. So we can use prostanoids. Prostanoids. What prostanoids can be used? Iloprost is an example. Iloprost is an example. So these are the class of drugs. We have a new drug called as guanylate cyclase modulator. which is called as riociguat. Riociguat. So these are the drugs we have. Now we have to just write down a little bit about the approach. How do we make the initial management? Should I use calcium channel blockers, or should I use phosphodiesterase 5 inhibitors, or should I use prostanoids, or should I use guanylate cyclase agonist? What should I use? Approach to pulmonary arterial hypertension. This is the last thing, and then we are done for now. How do I approach, right? So it all starts in the cath lab itself. Once I make a diagnosis, when mean pulmonary artery pressure is more than or equal to 20 millimeters of mercury with no lung or heart disease, it is diagnosed as pulmonary arterial hypertension, right? After that, what I have to do is we do a test called as vasoreactivity testing. Just like how we did bronchodilatory testing for asthma versus COPD, it is called vasoreactivity testing. Now, what do we do in this? We administer a vasodilator, like it can be nitric oxide or a prostanoid, to the patient and see what happens to his pulmonary artery mean pressure, how much increases. So in this vasoreactivity testing, we can use nitric oxide or prostanoids and then check his mean pulmonary artery pressure. If the mean pulmonary artery pressure increases by more than or equal to, sorry, not increase, I'm expecting it to decrease, decreases by more than or equal to 10 millimeters of mercury to a final value of less than 40 millimeters of mercury. I will try to explain this to you just now, just note it down for now. In that case, we would say vasoreactivity testing is positive. Such patients respond beautifully well to calcium channel blockers. And calcium channel blockers, amlodipine, is damn cheap. All these prostanoids, sildenafil, they're used for other indications, so they're damn expensive. So we can treat these patients with cost-effective treatment, right? So in that case, treatment will be dihydropyridine calcium channel blockers. If MPAP does not satisfy this criteria, right, means there is either not 10 millimeters drop or final value is not less than 40 millimeters of mercury, then we would say vasoreactivity testing is negative, right? Such patients can be treated with either we can treat them with prostanoids or phosphodiesterase 5 inhibitors, or we can think of riociguat, which is guanylyl cyclase stimulator, riociguat. These are the drugs we can think of using. We cannot use calcium channel blockers for these patients who are having vasoreactivity testing negative. Okay. Now I want you to be able to write this precisely how I have written. So I will try to make you remember it better. What does this mean? Let us say I have diagnosed a patient with mean pulmonary artery pressure was, let me say it was 50 millimeters of mercury. When it is more than or equal to 20, it is pulmonary hypertension. So pulmonary hypertension diagnosis is done. I have done CT scan and echo and heart and lungs are fine. So then the diagnosis becomes pulmonary arterial hypertension. Okay, that is done. Now I give them a inhaled nitric oxide or some prostanoid, right, as a vasodilator. After that, I recheck the MPAP, right, after vasoreactivity testing. If the mean pulmonary artery pressure now becomes, let us say, 41 millimeters of mercury after vasoreactivity testing, can I say it is positive? No. Why it is not positive? To be called it as positive, the drop should be at least 10 millimeters of mercury. And after the drop, the final value that I get should be less than 40 millimeters of mercury. So here the drop is neither 10 millimeters of mercury. The final value is also not under 40. So this will be counted as negative. On the other hand, let me flip the numbers and say it was 60 and it became 42. It is still negative. The drop is 18, more than 10, but final value is not less than 40. It is still negative. So these all patients will be treated with these drugs. On the other hand, let me say it was 40 and 5, let me say it was 48 and the final value becomes 37. The drop is more than 10, it is 11, and the final value is less than 40. Then it is positive. Such patients will be treated with calcium channel blockers. Okay. So that completes our discussion of the pulmonary hypertension with a brief on pulmonary arterial hypertension. We will take a quick recap and then wind up for today. The other question I will take it up tomorrow because we are already running ahead of. So what is pulmonary hypertension? It is the increased blood pressure in pulmonary artery. Criteria wise, it is defined as mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. The causes can be grouped into 5 groups. The group 2 is where left heart diseases resulted in pulmonary hypertension. Group 3 is when lung diseases resulted in pulmonary hypertension. And group 1 is where there is no lung or the heart disease. Artery is the problem, we will call it as group 1. Apart from that, there are 2 more groups. One, because of repeated embolism, if it is happening, it is group 4. And if the causes are not known, it is group 5. Few things we should remember here. Left heart disease, what can cause? Anything that affects the left heart, right? Mitral stenosis, mitral regurgitation, MS, MR, left heart failure, aortic stenosis, AR, any of them can cause. What lung diseases can cause? The most common lung disease that is known to cause pulmonary hypertension is COPD, right? Apart from that, interstitial lung disease can also cause. Okay, so this is about grouping. Then coming to the specific category called as pulmonary arterial hypertension. Definition wise, it is pulmonary hypertension without lung and heart problems. We have put it on group 1. It is most cases idiopathic, but sometimes it can be because of scleroderma, drugs and HIV. When it comes to drugs, I want you to remember an example, which is sibutramine. It was withdrawn from the market because it was causing pulmonary hypertension. And one more drug called as fenformin. Once upon a time, we used to use them for treatment of obesity. We have taken them off because of pulmonary hypertension. Symptoms wise, shortness of breath. Physical examination points, mainly you should mention loud P2. I want you to remember it forever in your life that loud P2 is equal to pulmonary hypertension. In cardiology, in ward discussion, practical examination, everywhere they will ask you about it. Loud P2 is equal to pulmonary hypertension. Diagnosis. 2D echo is not suitable for diagnosis. We can only use it for screening because it can only record the systolic BP, but the criteria is based on mean pulmonary artery pressure, not systolic alone. So for mean, we can only calculate when we catheterize the right heart. So RHC is the investigation of choice, where MPAP should be more than 20 to call it as pulmonary hypertension. And to call it as pulmonary arterial hypertension, lung and heart should be fine. How do we manage? Poor prognosis. Management is very, very important. We have a list of drugs available. Either they cause vasodilatation or modulate the substances involved in vasoconstriction, like endothelin, right? So most commonly used drug is calcium channel blockers, but they are only suitable if vasodilatory testing is positive. So that is why you have to write this approach. For diagnosis, we do a right heart catheterization, and once the right heart catheterization is done, we will check the MPAP. MPAP confirms that it is pulmonary hypertension, and we have ruled out lung and heart. It is pulmonary arterial hypertension. After that, we go for vasoreactivity testing. In the vasoreactivity testing, we give a vasodilator. If vasodilation results in sufficient drop in pulmonary artery pressure, we will treat it with calcium channel blockers. If the drop is not sufficient, calcium channel blockers won't work for them. Other drugs that we have listed can be used for the patient. And for those who want to remember how do I treat the other groups of pulmonary hypertension, we focused on pulmonary arterial. How do we treat, right? So how do I treat group 2? Of course, treat the underlying cause. For all of them, treat underlying cause. We don't have any specific pharmacotherapy. If it is MS which is causing, treat the MS, do the balloon valvotomy. If it is thromboembolism, consider giving the anticoagulants. Right. If it is COPD, try to treat the COPD. So we only treat the underlying cause. Only for group 1, we have this approach. Okay. So that's it for today. I have lined up one more question from the respiratory system, which is respiratory failure. The kind of question they ask you is define what is respiratory failure, classify it into 4 groups, and then discuss about the management, which is just a 10-minute job. We will take it up tomorrow and then start with the remaining questions, right? So for today, we will wind up. I'll see you all tomorrow. This PDF will be available on the Telegram as well as the MedEd app, from where you can download it and go through it. Try to follow the approach that we have followed. It will please the examiner and give you the maximum marks. After all, theory exam is all about writing and pleasing the examiner rather than knowing the objective information, right? So with that, I'm signing off. I'll see you tomorrow. Good night, guys.